first time. احنا بنتكلم على نفسنا يعني. شكرا دكتور هاني. بسم الله الرحمن الرحيم. I have the honor to introduce two of the eminent radiation oncologists and physicists in the world. Actually, we have today with us Professor Carolyn Freeman. She is a Mitchell Rosenblum Chair of Radiation Oncology in McGill University, Montreal, Canada. She is the head of the Department of Radiation Oncology, and she is also responsible for the pediatric oncology. So we have the honor to have her with us today. She was graduated from Westminster Medical School in London University, and she went in 1974 to Montreal, Canada, and she was there. They were lucky to have her all this time. Her final specialty is pediatric radiotherapy, and the subspecialty in pediatric radiotherapy is pediatric CNS tumors and soft tissue sarcoma. She is a board member in many international treatment groups like the CCHE and other groups. Of course, she published more than 100 international publications. The second guest is our second guest is William Barker. He was graduated from McGill University and has the master's degree in medical physics from McGill also, and he's a fellow of the Canadian College for Physicians and Medical Physicists. He works as a chief medical physicist in McGill University, Montreal, Canada, and he is also a member of the IAEA auditing team. And from my reading, he has a vast experience in the IMRT, IGRT, tomography, and quality assurance program, as we will notice after he will finish his presentation. And he has many publications in the international journal. And today, may I introduce Dr. Carolyn Freeman to present her first presentation.
Thank you very much, Dr. Mohammed. And I can't tell you how pleased we are to be here. We've had a wonderful week. And the staff here, especially Dr. Mohammed, led by Dr. Mohammed, has been very kind to us and very welcoming, and we've had a wonderful week with you. So my talk today, my first talk today, is going to be about progress in pediatric radiation oncology, really leading on to the other talks that are going to be taking place later on in this session. So as you all know, the overall 5-year survival rate has been increasing. In North America, the increase has been from something just less than 60% to something just more than 80% now. And these are population-based data from registries throughout the United States. And this is due to improvements in surgery and perioperative care, the use of chemotherapy, better agents, better regimens, better supportive care, and I would say better integration of all of the treatment modalities into the general therapeutic plan. And I think that we all agree that radiotherapy is a very important component of treatment that makes a contribution both to local control and event-free survival, but also to overall survival. The major concern, of course, with the use of radiotherapy in children is for late effects. And this has led to significant variations in practice throughout the world, depending on one's philosophy in this regard. There's been a lot of progress in pediatric radiotherapy, both in parallel with improved overall treatment. So we see refined indications for radiotherapy in the first place. We see volume reductions, treatment volume reductions, or volumes reductions tailored to response to chemotherapy, for example. We see dose reductions and doses tailored to response as well. And then there have been improvements that are specific to radiotherapy. So improved targeting, better delivery methods, and I would say in North America, a lot of the progress, or a significant amount of the progress, is due to the work that we do within the cooperative groups. So not only do we have quality assurance for every treatment and for departments that participate in clinical trials, but there is also a very important educational component to our participation in these clinical trials. So that at our semi-annual meetings, for example, we have educational sessions on radiotherapy, and this has been a major advantage, I would say. So what I'm going to be introducing today is I'm going to talk a little bit about improved targeting, and I'm going to talk a little bit about intensity modulated radiotherapy. Not the technical side of it, because William's going to talk about that later, but I'm going to talk about what the advantages might be and what the lessons we've learned as we've implemented intensity modulated radiotherapy in children, and talk about some of the concerns as well. So improved targeting really starts with improved diagnostic imaging for tumors in general. The advent of CT simulation in the early 90s in North America. The ability now to co-register images, appropriate images to the planning CT, so MRI or PET scan. And now, of course, we're talking as well about functional imaging for treatment planning. So, as I said, we've come quite a long way. The kind of studies that were available to us until the early 1990s allowed only rather imprecise definition of target volume, and of course, as a result, we had to use much larger treatment margins. Now, as I said earlier, CT simulation is now absolutely routine, and we use image co-registration to the planning CT scan for target volume definition, so that we would use an MRI, for example, for planning CNS tumors, treatment of CNS tumors, and for treatment of sarcomas, whereas we might use PET-CT for Hodgkin's lymphomas. Just giving you a couple of examples there. I'm going to, because a lot of this first part of the afternoon is going to be talking about medulloblastoma and craniospinal radiotherapy, I'm going to use craniospinal radiotherapy as an example of progress and talk about targeting in craniospinal radiotherapy. So CSI is a complex technique that's used in North America, at least. Here it's used many, many times every year. But in North America, this is something that one would do perhaps 3 or 4 times a year only. So that no department is very, it's a complex technique. It should not be done in smaller treatment departments, for example. And the fact of the matter is that targeting deviations have been very frequent and have been shown over the years, going back many years now, to correlate with outcomes. And as we reduce the doses in craniospinal radiotherapy, first of all to 23.4 gray, and now really as low as 18 gray, it becomes really imperative that we make sure to adequately cover the tumor, the target volume. So the clinical target volume, as you know, is the whole brain and the spinal cord with the overlying meninges. The problem areas are the frontal region and the caudal extent of the thecal sac. And it's really impossible to adequately cover the cribriform plate without using CT simulation. And it's also impossible in most patients, not all patients, but in most patients, to shield the eye and adequately cover the target volume. And if you don't adequately cover the frontal region, you risk recurrence. Oops. As you see here in the subfrontal region. Then for the lateral aspect of the spinal target, traditionally we've been talking about margins that are 1 centimeter lateral to the pedicles to include the whole vertebra, and even widening caudally to cover the sacral foramen. And traditionally the lower limit has been the bottom of the S2 foramen. But in fact, what we really need to do is to use a field that's wide enough to ensure coverage of the CTV, and also in young children, and particularly those being treated with higher doses, to avoid dose heterogeneity in the bone. And if we reduce the width of the spine field, we can see significant normal tissue sparing, and particularly here, the heart and the lungs. For the distal limit of the of the spine field too, traditionally it's been at the bottom of the sacral foramen, but we know very well that that's not always the case. And in fact, in a significant percentage of patients, the thecal sac ends more proximally. And MRI is really essential for accurate determination of the caudal extent of the thecal sac. And here you see the distal end very nicely, as you can see, if anybody can see, an MRI done for another reason, as Ewing sarcoma in the pelvis, but you see a very precise delineation of the caudal extent of the thecal sac using MRI. And MRI is really essential for that purpose. And what we showed is that moving from 2D to 3D imaging using CT scanning and all appropriate imaging for target volume definition in the spinal region, we were able to significantly decrease the integral dose during treatment. So then, just to summarize, target volume definition is very important, and I would say perhaps the most important single factor for improving craniospinal irradiation. CT then for target volume definition for the brain fields, MRI for the caudal extent of the thecal sac, and we need to pay special attention, as I said, to the width of the spinal field. So with this, we can be sure of adequate coverage of the target volume, and we also know that we can reduce significantly the volume of normal tissues that are irradiated. And we really believe that this may have contributed in some part to the improved survival that we're seeing in patients with medulloblastoma. Just to finish the discussion on targeting, of course, now we're talking about functional imaging as well. And it may well be that we will be using functional imaging, PET scan or SPECT, routinely for delineating the target, perhaps giving a higher dose to a more biologically active component of the target, as in this case a glioblastoma multiforme. Or, and this is important too, and this is really, I would say, not perhaps very likely, for selective avoidance of normal brain, as we're now able to do. So now I'd like to talk a little bit more about, improved delivery, really leading into the other talks later in the afternoon. So CT scan in the CT simulation in the early 90s really led into the era of 3D conformal radiotherapy, and with that we were able to see better targeting and a greater probability of tumor control with a lower risk of complications. If we take the example of the posterior fossa boost in a patient with medulloblastoma, we're moving from image lateral or orthogonal X-rays, where we treat a block of tissue, including a large amount of normal brain, to an area of 3D treatment planning and delivery, where we can decrease the dose to the structures outside the target volume, such as the cochlea, such as the hypothalamus pituitary, and we also can decrease the amount of supratentorial brain in the treated volume. With the IMRT, as you'll know, this is instead of using homogeneous or uniform radiation beam intensity, we use non-uniform intensity beams. This can be delivered in a variety of different ways, and will talk a little bit more about this. But what I'm showing you here is the a linear accelerator with an MLC and the non-uniform dose intensity map. And this has a number of different advantages or different uses in radiotherapy practice. It may be used simply to improve the dose distribution in a regularly shaped target, and I think we'll show you an example of that. You can also consider delivering differential doses within the target, or you can use it to improve sparing of critical structures or selective avoidance. And using the same example as before with IMRT, we were able to show this is one of our first IMRT plans actually, but we were able to show further decreased dose to the critical structures, and here you see very well the increased sparing of the supratentorial brain. I'm just going to give you 2 or 3 other examples here of improved sparing of critical structures. This is a child with a nasopharyngeal carcinoma with good sparing of the mouth, or better sparing of the mouth than we were able to achieve in the past, and also of the parotid glands, which you see well here on the axial cuts. In retinoblastoma, we were able to show that IMRT provided better orbital bone sparing and better sparing of the bone than either 3D conformal radiotherapy or stereotactic radiotherapy. And this is a patient with Hodgkin's disease where we were able to treat tumor around the heart with significant sparing of the heart. And IMRT, as I said before, could also be used for dose escalation. This is another child with a nasopharyngeal carcinoma where we're using a different dose to the primary tumor from the tumor in the neck, in nodes in the neck, to the uninvolved neck with good sparing of the spinal cord. And this is a child with an ependymoma where the goal was actually to deliver a higher dose and a higher dose per fraction to the surgical bed with residual tumor on the edge of the surgical bed than the surrounding normal brain. IMRT, you'll see more examples of this again with, this is IMRT delivered with tomotherapy, where we were able to use IMRT for dose reduction to part of the treated volume. This is a child who'd been treated for medulloblastoma and with low-dose craniospinal radiotherapy at the age of 3 years, who failed in the, with metastatic disease on the S1 nerve root, who had reirradiation, including to the posterior fossa, with reduced dose to the previously treated target. So what you read about and what you hear about at meetings is potential disadvantages of IMRT, and especially the increased volume of tissue that's exposed to low doses. Because of the larger number of beams and the exposure of more non-target tissue because of the increased number of monitor units for treatment delivery. And also there is some concern about the use of non-uniform doses both within the target and within the organs at risk, which leads to certain uncertainties with respect to treatment outcomes. So there are concerns with respect to low-dose effects, particularly at doses less than 1 gray per fraction, because of the possibility that this may, in fact, trigger a hypersensitivity reaction and perhaps an adaptive response to radiotherapy, which is documented in vitro, and perhaps, we don't know, to chemoresistance as well. And then there's the potential for molecular changes that may lead to second malignancies. And this has led some people, most famously Eric Hall, but not only Eric Hall, to say that in fact IMRT should not be used in children. But of course several factors have to be considered, including the size of the target volume, the delivery technique, we can talk about these if later, the location of the tumor, and also the competing risks. And I'll try to explain what I mean by that. In craniospinal radiotherapy, we have a long list of known potential adverse effects, including growth disturbances, primary hypothyroidism, impaired lung function, effects on the heart, which are very well documented now, primary ovarian failure, and second malignancies. And we know that most of those are related in some way to the radiation and can be modified by changing the dose or the energy or the technique used. Perhaps also the modality, and I'll come back to that in a minute. But there are other factors at play, including the use of chemotherapy. Chemotherapy is used more than in the past in patients with medulloblastoma. There's the effect of endocrine effects, deficits, particularly thyroid and growth hormone deficiency on the risk of heart disease, exercise or lack of it in patients with a persistent neurological deficit, and so on. What we know about IMRT is that we can show improved sparing of structures anterior to the target, and we believe that this is a very important consideration. So where are we now with craniospinal radiotherapy? We have better positioning and immobilization techniques. The use of daily anesthesia is much more routine now than in the past. The supine position is much more comfortable for the patient and much more reproducible, and also safer if anesthesia is required. We have much better target volume definition than in the past, which I showed you, and we believe that we also have better treatment delivery using IMRT because of the decreased dose to the heart in particular. What we don't have, many of us at this point, is proton therapy. But until we have proton therapy, our goal with IMRT is to mimic proton therapy as best as possible with improved sparing of the anterior structures. But clearly, at this point, proton therapy plans are much superior for patients with medulloblastoma. So with respect to the implementation of IMRT, I think that we can say that we've learned quite a lot of things over the last 8 or 9 or so years. Target volume definition is absolutely critical and not always that easy. We need optimal imaging and co-registration of images, as I said. Sometimes we need to adapt the target volume as a result of changes in anatomy following surgery, and the margins themselves are changing. Sometimes there are significant uncertainties as to what is actually required for margins. We have much better external immobilization, but we need to monitor any, not so much in CNS tumors, but in other situations, inter and intrafraction motion and changes in tumor volume during treatment, which would have a much more significant impact than in other treatment delivery methods that we would have used in the past. Dose prescription is much more complex. The dose to the macroscopic disease can be different from that used in the past. It could be higher, it can be inhomogeneous, as I said earlier. The dose to the surrounding tissues may also be different. It could be lower, it could be higher, it can be inhomogeneous, almost certainly will be. And we don't really know what the tolerance is to partial or inhomogeneous irradiation at this point. We also don't know the clinical relevance of low-dose exposure of a larger volume of normal tissue outside the volume. What we also know is that treatment planning and quality assurance procedures are much more time-consuming, and I would also say that the close interaction between the members of the team within the radiation department and with other members of the treatment team has never been more important. I mean, perhaps it's always been very important, but now we need often to discuss very technical aspects of the treatment plan at multiple time points during the management. So both to plan the overall management strategy, to ensure that planning is optimal and treatment is optimal, and also we need to very, very carefully evaluate our outcomes, most particularly patterns of failure in the context of the changing margins, and also adverse events. Thank you.
Yeah. So good afternoon, and I'd like to start off by thanking Dr. Mohammed Saad for having us over here, and also Comprehensive Cancer Care for making all the arrangements possible. It's a Canadian company that's helping up many of the departments in this hospital. We're here, of course, to evaluate and to help the pediatric radiation oncology a facility over here, which we have to say is state of the art. I'd like to congratulate Dr. Hani actually on a fantastic hospital overall. So the first discussion is going to be a little bit more technical than Dr. Freeman's discussion, but based around whole CNS irradiation. Like everyone, we started using the well-established technique published in '77 by Jake Van Dyke, and it basically, used a pair of lateral opposed fields to treat the brain, and then a series of one or more posterior fields to treat the spinal cord. The problems with these techniques, they're actually well known. The craniospinal junction, the junction of the posterior fields, and of course, treating with direct fields leads to dose gradient through the dose distribution. Additionally, like Dr. Freeman mentioned, conventional blocking techniques using a simulator can sometimes lead to target misses. Later on in the 90s, Faiz Khan published it was in a textbook, but the actual conventional technique suggesting either an isocenter by the outer canthus of the eye or actually using a half block. But it still was a technique with the prone position and an SSD setup. This, of course, can cause problems in the junctioning of the fields. So I'm going to talk about how the technique has evolved at McGill University and all of the changes that have happened basically in the last 10 years, starting with the implementation of the supine position through using CT for simulation, using the Linacs more efficiently to provide a safer beam geometry for the patients, all the way down to intensity modulated radiotherapy and tomotherapy for the treatment. This is actually a picture of a patient that we took just the week before we came. And this is our new immobilization a system for craniospinal patients that will be on the tomotherapy unit. You notice we use a head and shoulder mask now. We no longer have to recline the patient's head. We have airway access if we need it for anesthesia, and the position itself is very comfortable for the patient. The first thing we tried to do with the technique was to actually simplify the technique itself. So putting the patient in a prone position is uncomfortable, but using direct field SSD setups for this particular technique was cumbersome. And a difficult technique, and led to problems in the junctioning. So we figured that when the new Linacs came in the mid-90s, early 2000s, that had the ability to use asymmetric jaws and isocentric delivery, once these became standard equipment, we would be able to use these to help us treat the patient. Everything starts, of course, with the CT simulation. And Dr. Freeman touched on this, but the outlining of the brain, in particular, just below the cribriform plate, is critical for avoiding target misses. And then the technique is now done on a virtual simulator. Okay, so we use the CT information to generate these synthetic X-rays called DRRs, and we have a fixed geometry. So the head or helmet field is always 20 centimeters long. And we have the isocenter always at this position, and then we have a nice junction with the posterior fields. The blocking, of course, is done as a function of the target, the target drawing, which in this case is the brain plus a margin. We use a 3 millimeter margin near the brain, and then the field edge over here is 7 millimeters from this planning target volume. We have adopted the MLC for the blocking. goal is always to treat the brain. We forget about the lenses and the eyes. We'll treat through them if we have to. This is a technique for a small child, and we can see the single lysocenter over here close to the C2 vertebrae, and then the MLC coming all around. We always use 20 centimeters here. We always use 20 centimeters here. This always gives us 11 degrees. Okay, and then we just adjust the inferior limit with the asymmetric jaw. So this becomes very easy to apply on the machine, and we feel a very safe technique. For either adult patients or grown children, we can apply a second posterior field. Normally, Linacs have a field size or length restriction of 40 centimeters. We, again, use fixed parameters, still 20, still 11, still 20 over here, but this field is 30 centimeters away. And again, this side is going to be 10, and then we simply adjust the caudal end of the field with the asymmetric jaws. Dr. Freeman commented on this before. The field limits can be done or determined either from the CT simulation and then subsequent DRR. We prefer to use MRI for a more precise field definition. Junctioning. With this technique, junctioning is obviously still a problem. We don't want any overlaps or underlaps here or here. So what we do is, this is our starting configuration, so 20 centimeter length, 40 length, and then 10 plus whatever is required to cover. And then every week we move the junction by 1 centimeter. So this would be the first shift. So this is 20 centimeters now plus 1, because this is 38, so 19 and 19. This becomes 11. And then after the second week, we now have 22, which is 20 plus 2. This is now 36. This is 12. And this stays locked in the position. So this is, we feel, a very safe technique. You're not moving the patient. You're not remarking the patient. You're simply using the features of a modern linear accelerator. The posterior fossa, again, Dr. Freeman spoke about this. This is her signature from a few years ago. We no longer do this. We prefer to use MRI, and here you see how MRI compares with CT. I've got to admit, the CT has no contrast. The CTs here have contrast, and you can actually see the posterior fossa quite well. But the MRI allows us to define more precisely where the disease is and boost sites which may be possible. So this is a CT, an MRI, and then this is actually a tomotherapy plan. I'll talk about that later, with very specific targeting to the primary disease site. Our next step was to actually use a simple IMRT, step and shoot, or planned IMRT, to do dose compensation. So this would be the distribution. If we prescribed somewhere over here, you would end up with a very inhomogeneous dose distribution with quite a gradient through the target. And by applying very simple IMRT, we can actually shape the field, and it's not even inverse planned IMRT. We can shape the field to follow the curvature of the actual spine, both for the superior and the inferior fields. We do this simply by adding different weighted fields onto the patient. So this would be the original field at 90% beam weight, and then since we need a little bit more penetration from this field, we would simply add a second field over here and then a third field over here. We're very lucky. Our Linacs are able to deliver these automatically, so we like to call it IMRT. If you prefer to view this on a DRR, this would be the initial field, again 90%, and then a small boost of 5 and a small boost of 5 up here to get that curved dose distribution. We then progressed to use inverse planned IMRT, and as Dr. Freeman explained previously, our goal was to reduce the target to a very compact target, and the first step was to go to 3D. But we still ended up with this very high dose to the anterior structures in the beam path. So we had gained some experience with IMRT, and then we decided to see if we could apply this using a 3 or 5 field combination to our spinal cord target over here. And it worked quite well. And we managed to show that not only did we have good anterior structure sparing, but the technique was actually better for coverage. The maximum dose was only there was only 3% of the volume receiving greater than 107%, where we had very different results for the 2D and the 3D technique. So the technique provided better target coverage, and it also provided critical structure sparing, namely in integral dose. The IMRT technique provided comparable integral dose for the whole body with the 3D, and much better than the actual 2D technique. The next step, and this is how we do all of our patients now, was to deliver the IMRT with a specialized machine. So I'm not sure if you guys know about the tomotherapy unit, but it looks like a CT scan and treats like a CT scan. There's a 6 MV Linac mounted on this rotating gantry. There are detectors down here, so we're able to image the patient before treatment. Let's do IMRT. The bore is similar to a CT scanner bore. It's 85 centimeters. There's a 64-leaf binary MLC. And what ends up happening, we have a very, very high dose rate. And the patient gets put through this in what we call a helical delivery. So the patient slides through, and this thing spins around exactly like a CT scanner. One of the very nice things about the tomotherapy unit is that we're able to image the patient every day before treatment with very low dose, okay, using megavoltage CT. This is an example for a craniospinal patient of an axial cut. And it's very nice. They shunt the beam down to 1.5 MV to increase the image quality. And it's a very low dose, which is good. This is less than a portal film, and certainly less than cone beam CT from nowadays. The system also has the ability to replan on the fly if you want. So you can image and then do a plan at the workstation before you treat the patient again. Unfortunately, that takes about an hour. The company thinks that's very reasonable, but we don't. So this is a comparison of showing a 2D or 3D technique with junctions compared to CSI. And the first thing that we notice is that we have a very conformal dose distribution, and we don't have a hot dose now posterior to the target. In fact, we have an extremely conformal dose. Without the hot spot, we have excellent anterior coverage. The green line here is, on both these images, is 18 gray, or 50% of the dose. This would be for a 36 gray patient. But we don't have these junctions. We don't have to worry about junctions. So the whole patient is translated through the beam at once. We have a lower maximum body dose in this one. I'm not sure, but this one gives 48 gray hot dose, and the prescription is 36. And this one only gives a 38 gray hot dose. So we save 10 gray, which is a quarter, almost a third, of the dose by using the tomotherapy when we're talking about the hot spot. We also have daily imaging, so that allows us to reduce our treatment margin. So we use between a 3 and a 5 millimeter PTV for when using this particular treatment configuration. Other advantages can be seen on the dose volume histogram. The blue lines are for the tomotherapy plan, and we can see the very, very sharp drop off, indicating excellent coverage and very good dose homogeneity. And we don't have these hotspots that are present for the 2 or 3D plans. What we also see is that the area under this curve and the area under this curve, believe it or not, are very similar, and that's an indication of the integral dose. Just some slides here showing you how the tomotherapy works. So every day the patient is put into the machine, and a CT scan is acquired, and the therapists are able to localize the patient. So everything in orange here is the MVCT, and anything in gray is the CT sim. And they simply, by using arrows, move one image onto another, registering the images, and then they're able to place the patient according to certain shifts defined by the image registration. And they can do this in the axial, sagittal, or coronal planes. Again, here we see a sagittal plane, and this is the MVCT, and then this would be what they call a KVCT. We would call it the CT simulation. The machine allows us to do some pretty neat things. I'm not sure if Dr. Freeman showed this slide before, but this is how we treat medulloblastoma now. Very conformal treatment, very few hot spots, and sparing of anterior structures and excellent target coverage. And I'm happy to report actually that the people, the physicists and the physician team here are able to get very similar distributions with the Siemens Linacs that they have installed over here. So hopefully they'll be able to do this in a short time. But generally the goal here is that we see is we get about a quarter of the dose as the average dose to all of the structures that we outline here. So that's actually quite remarkable. The machine allows us to do some very neat things. This particular patient had leptomeningeal metastases, so these little white spots all needed boost treatment, as well as some spots in the brain of the patient. So Dr. Freeman, for this particular case, decided that it would be a good idea to give all of those metastases a small boost dose. And this is what we've done. So everything in red has received 45 gray, and the rest of the craniospinal target received 40 gray. This slide was also shown. This patient had received previous treatment to the posterior fossa, and the request was to reduce the dose by 5 gray. So craniospinal irradiation, minus 5 gray to the posterior fossa, and we managed to do this. And again, note the very good sparing of the critical structures. Posterior fossa boost, we can make a little hole over here for cochlear sparing. So we're giving probably 23.4 gray plus another 30-something gray to the target. And notice that the cochlea are getting less than 10 gray. Okay, so this can have some important ramifications for the quality of life of the patient in the future. There are some planning issues. We do treat the face where we didn't treat the face before, so now we have to be concerned about parotid dose and dose to the mouth, teeth, etc. So the face must be drawn as a structure, and it must be considered in the treatment planning. The arm position can be variable, so this can be a problem if the patient has different arm positions day by day, because the patient is only planned how the patient's done on the CT. So what we can manage to do is actually draw boxes around the patient and then prevent the beam from coming this way. And this is the resulting distribution that we get. We can have small treatment margins, but one drawback of the system is that the imaging does take a long time. It takes a few minutes. So patient comfort is very important. And finally, we have a treatment time of between 10 to 15 minutes beam on. So the treatment is actually much longer with this type of technique than with IMRT, but it gets very, very good results. So what can we say in summary? We believe that the supine position is more comfortable, reproducible, and allows airway access. We have CT and MR and perhaps PET CT in the future for improved volume delineation. Virtual simulation with a simplified geometry we believe is safer treatment. IMRT can be used for simple dose compensation, or we can use inversely planned conformal IMRT. And certainly with tomotherapy, we've treated, I believe, 10 patients this way. And we're getting many referrals for this type of treatment. All of this information can be found in the usual suspects here of publications. So thank you very much.
Thank you. So continuing the theme of this part of the afternoon, I'm going to be talking about more clinical aspects of management of medulloblastoma and specifically the results of clinical trials in North America and just leading up to present-day treatments. So we all know that medulloblastoma is one of the small blue cell tumors of childhood that arises with one of two pictures, really, from two different germinal zones of the cerebellum, either the ventricular zone or the external granular layer. It's the most common malignant brain tumor in children, probably 15 to 20% of all in North America. And it's a tumor for which there's been tremendous progress over the last 20 years, both in treatment but also in understanding of the biology of the disease that allows us now to start thinking of medulloblastoma as being of one of several fairly distinct subtypes. So what I'm going to do today, as I said, is to review the management of medulloblastoma and to review evolving radiotherapy practice, and just tell you a little bit about the directions that the studies are taking in North America. The peak age of presentation is 7 years. Almost all cases occur in children, or at least 70% by the age of 16 years. And males are more often affected than females. It's associated with several familial cancer predisposition syndromes that are listed there. Overall, the frequency is about 10%, but it's more common to find associated predisposition syndromes in children less than 3 years of age, and it's been suggested that we should actually be screening for these syndromes in younger children. This is a very typical midline location with a tumor arising in the vermis, causing compression of the fourth ventricle, so that patients present with symptoms and signs of raised intracranial pressure. The other presentation, which is more common in adults or in very young children, and more often of the desmoplastic type, is the lateral lesion that you can see here in the hemisphere on the left. About a quarter of patients have leptomeningeal seeding at diagnosis, but the frequency is more common, the frequency is greater in infants and very young children. So for workup, we need a postoperative MRI performed within 24 to 48 hours after the surgery. An MRI of the spine, if it hasn't been done before surgery, would be done more than 3 weeks postoperatively, so that we don't see artifacts due to the surgery. And we also need for a staging workup lumbar CSF cytology performed at least 10 days following surgery. And the prognosis depends on the extent of the primary tumor, or rather the completeness of surgical resection, and whether or not there's any evidence of leptomeningeal seeding. And for management, we divide patients into 3 groups. A standard risk patient is a patient that's had a complete resection or who has residual tumor less than 1.5 centimeters squared on that postoperative MRI, and has no evidence of leptomeningeal seeding either by MRI of the spine or by CSF cytology. And all other children over the age of 3 years will be categorized as high risk, and that category is probably around 1/3 to a half of all patients. And then there's medulloblastoma in infant and very young children, which may well be biologically different and is certainly treated differently. So I'm going to talk about treatment for each of those groups of patients. So starting with standard risk medulloblastoma, until recently, craniospinal radiotherapy alone was the standard of care. Typically, the dose was 35 to 36 gray to the whole craniospinal axis, followed by a boost to the whole posterior fossa, up to a total dose of 54 to 55.8 gray. We know that long-term survival following such treatment is around 60 to 65% of all patients, and we also know that these patients are likely to suffer very predictable sequelae of treatment that you can see listed here. So endocrine deficits due to radiation to the hypothalamus pituitary, to the thyroid, effects on growth and musculoskeletal development that are partly related to growth hormone deficiency, but also to the direct effect of radiation. And of course, the effects on learning ability and academic performance that translates into problems with social integration and vocation and so on. So the rationale then for looking at alternative approaches to treatment in standard and risk medulloblastoma is to improve tumor control, because we don't consider 65% very good, and also, of course, to reduce the morbidity of treatment. And a number of different approaches have been taken. One is to use reduced dose craniospinal radiotherapy alone, or rather radiotherapy using reduced dose craniospinal radiotherapy together with a boost. So no chemotherapy. Another approach is hyperfractionated radiotherapy, which has been pursued by several European groups. Or the alternative is to use reduced dose radiotherapy in combination with chemotherapy. And this slide just shows a summary of all of the studies that were done looking at reduced dose radiotherapy alone, which is clearly inferior to standard dose radiotherapy. And here you see the combination of reduced dose radiotherapy, 23.4 gray, together with chemotherapy according to the PACA regimen, with results from those early studies very similar to radiotherapy alone. So the next step, this became in North America the new standard of care. In other words, patients would have maximal surgical resection followed by postoperative radiotherapy using reduced dose craniospinal radiotherapy plus a boost to the same dose, to the standard dose to the posterior fossa. And the chemotherapy consisted of vincristine given weekly during radiotherapy, and then adjuvant systemic chemotherapy with vincristine, cisplatin, and CCNU for a total of 8 cycles that would be started following radiotherapy. The next study that was done in North America looked at this regimen, the CCNU, platinum, vincristine, and compared that randomized patients to receive, instead of CCNU, cyclophosphamide, cisplatinum, and vincristine. And the patients were given the same low-dose craniospinal radiotherapy. And this is these are the survival curves. They're published in 2006 that show excellent, better progression-free survival, with progression-free survival at 3 years greater than 80%. And this is compared with low-dose radiotherapy alone and standard dose radiotherapy alone. So that where we are now with standard risk medulloblastoma is that reduced dose radiotherapy together with chemotherapy results in better event-free survival with fewer systemic and late recurrences and reduced sequelae, including reduced neurocognitive sequelae of treatment. But of course there's additional toxicity due to the chemotherapy, including vincristine neurotoxicity, more ototoxicity due to the cisplatin, more hematologic toxicity and infections and so on. So where are we now with treatment of standard risk medulloblastoma? We're interested in reducing the risk of morbidity of treatment, so optimizing the chemotherapy, not only to reduce the toxicity due to chemotherapy, but also possibly to allow further reduction of radiotherapy dose. And also we're looking at reducing the radiotherapy target volume for the boost. And this is the current study, which is probably around 80% complete at this point. So within 4 weeks following the surgery, patients undergo radiotherapy together with vincristine given weekly during radiotherapy. And then after a break of 4 weeks, they go on to adjuvant chemotherapy with a regimen that is a blend of the standard PACA regimen alternating with vincristine cyclophosphamide. This is a radiotherapy study, and the first randomization is for children under the age of 8. There's a randomization for between the ages of 3 and 8. Patients are randomized to either 18 gray craniospinal or the standard 23.4 gray craniospinal. The second randomization is for treatment in all age groups between 3 and 21 to either a standard posterior fossa boost, whole posterior fossa, versus a conformal boost to the posterior fossa. And so far, as I said, this was the study is about 80% complete at this point. The use of conformal radiotherapy to the tumor bed can be justified on the basis of a number of institutional studies from Memorial at the time and St. Jude now, from Memorial, from Minneapolis, and from France, which shows that it's very rare, in fact, it's very unusual to see isolated failure in the posterior fossa outside the boost volume. And it's clear that the boost volume is defined here. The GTV for the boost is the tumor bed together with any macroscopic residual disease, taking account of any changes that have happened since the surgery, with a margin for the CTV of 1.5 centimeters. And this allows, I showed you this before, and this is, I said before, an old IMRT plan, but we can see with this improved sparing of the cochlea and the temporal lobes. This study has stopping rules for excessive failure in the neuroaxis, which is of course important because of the reduced dose to the craniospinal axis and to the posterior fossa outside the tumor bed. And of course we are measuring carefully long-term sequelae of treatment, including neuropsychological effects and neuroendocrine and ototoxicity side effects. And we're also looking at biological correlates with outcome, and the plan is to be in a position to use biological markers to stratify patients for the next generation of trials. Now, when using reduced dose craniospinal radiotherapy, there are a number of considerations. The quality of radiotherapy, as I tried to say in the first talk, is really very important. And on this study, real-time review is required by a central quality assurance review centers within the first 3 days of treatment, so that if the fields are not appropriate, the treating radiation oncologist will receive a call and an adjustment can be made. The other consideration is that patients with excessive anaplasia are shown to have a worse outcome. And in fact, in the new WHO classification, there's two new classes actually. Medulloblastoma with extensive nodularity, which is favorable, and anaplastic medulloblastoma, which is now considered unfavorable. And so these patients are now being moved into higher risk category. The other very important consideration is the importance of complete and accurate staging. And this is from the same paper from 2006 by Roger Packer, showing that those patients who, in fact, on central neuroradiology review of the imaging studies were found, in fact, to have disseminated disease, although that had not, the films had been interpreted differently by the centers themselves, had a very poor 5-year event-free survival. So careful, adequate imaging, optimal imaging, and careful review of imaging is very important if you're going to treat patients with reduced treatment. So just moving on now to high-risk medulloblastoma, the prognosis in the past was very poor, with survival rates variously between 0 and 25%. So clearly the goal of treatment now is to improve tumor control and survival. I just want to repeat here that the definition of high-risk disease is changing, as the definition of low-risk disease or standard risk disease is changing. So until recently, it would have been a residual tumor more than 1.5 centimeters squared on the postoperative MRI and or leptomeningeal seeding. Now also this category includes unfavorable pathology, so large cell medulloblastoma and anaplastic medulloblastoma. The management of high-risk medulloblastoma is not standard. The treatment approach could be any one of a number of different chemotherapy approaches, including, as you can see here, pre-radiotherapy chemotherapy given concurrent with radiotherapy as a radiosensitizing agent, early intensification of chemotherapy given by other routes, high-dose chemotherapy with autologous rescue. And two, there are considerations for modifications to radiotherapy, such as boosts to macroscopic residual, if that's the only site of disease at the primary site, higher dose craniospinal radiotherapy, different fractionation schedules, including hyperfractionated or hyperfractionated accelerated treatment. And the survival rate has improved from 0 to 40, as I quoted before, to at least 60% now. This is a study that was done by the pediatric oncology group before the merge of the two groups. using higher dose craniospinal radiotherapy of 40 Gray for patients with M2 and M3 disease. And you can see the survival for all of those categories, including M2-3 disease, was greater than 60%. This was a pilot study that was done in the Children's Oncology Group, where patients received vincristine and carboplatin concurrent with the radiotherapy, and then went on post-treatment to receive either cisplatin, cyclophosphamide and vincristine, or cyclophosphamide vincristine. And these are the results of that study. This is a pilot study. So with a small number of patients, the overall survival here at 3 years was more than 80%. And this compares with previous study but as I said before, we can think that the groups may not be the same. There's been some stage migration. Certainly it may be due to better or more intensive chemotherapy. It could be due to better radiotherapy or high-dose radiotherapy, but there has been stage migration. So that patients who would have been in a more favorable category before are now in the high-risk category. This is the current study that was built on that pilot study. So the questions in the study are either vincristine alone or vincristine plus carboplatin during radiotherapy, and then following radiotherapy, the use of cis-retinoic acid as maintenance or not. And this is a study that's been open for a couple of years now, and the accrual is ongoing. So the radiotherapy is craniospinal radiotherapy to a dose of 36 Gray with boost to any macroscopic disease. Again, there's a requirement for biology studies so that this can be used for future studies. So with respect to radiotherapy for patients treated off study, I think the standard of care is standard dose craniospinal radiotherapy followed by a boost to the whole posterior fossa. For patients who have residual disease, we can consider a boost to the macroscopic residual if that's feasible. For patients with disseminated leptomeningeal disease, the CSI dose is usually of the order of 40 Gray, and again, we should consider a boost if that's feasible. Just a few words about the management of medulloblastoma in infants. In general, infants with medulloblastoma have a worse outcome, and of course the concerns with respect to neurocognitive sequelae are very valid. But it's of note that you see significant neurocognitive sequelae even after treatment with chemotherapy alone. Patients who have a complete resection and do not have leptomeningeal disease actually do rather well, with overall survival, as you can see here, as high as 69 or 93%. On the other hand, patients who have macroscopic leptomeningeal disease do not do so well, and they don't do so well with chemotherapy alone. Not that many achieve a complete response, and certainly not a durable response. So the current studies for medulloblastoma in infants for standard risk disease, so patients without more than minimum residual disease and without leptomeningeal disease, they have surgery, they have chemotherapy, they have second surgery if they'd had residual disease and if it's feasible, and then they go on to receive age and response-based conformal radiotherapy. They don't receive craniospinal radiotherapy. For patients with high-risk disease, the study question at this time is what is the added benefit of high-dose methotrexate? Again, radiotherapy is based on age, extent of disease, and response, but not necessarily CSI. In fact, there is no standard of care really for the use of radiotherapy in children, and on most of the studies it's worded as at the discretion of the investigator. And in this table I just listed all the doses that can be used, as I say, ranging from 0 to pretty high or standard doses. So, as I said, there's no standard of care. It's quite likely that the best approach will be a good use of all modalities, and the COG is developing with the French and German and UK groups an international study that will likely test all of the various approaches that are used, at least in Europe and in North America. What's clear, I think, is that the next generation of studies will use biological markers for stratification of treatment, and likely molecularly targeted therapies will be used as well. So thank you.
Bismillah ar-Rahman ar-Rahim. I'm going to speak about the Children's Cancer Hospital Egypt experience in medulloblastoma and craniospinal irradiation. We have here, we received 1,431 patients during the period from the start of the hospital running on the 7th of July 2007 till the end of 2008. And the 226 out of these were brain tumors. And the out of these, 23% are medulloblastoma. The medulloblastoma, as I mentioned, were 23% of the brain tumor that we received. As Professor Freeman said, it occurs in the posterior fossa and it arises in the middle line of the cerebellum and spread to the inside of the fourth ventricle and brain stem. And it has a high propensity to spread through the CSF, and it is reported that 30% of the patients presented with CSF affection, either seedling or cells in the CSF. We have patients, our patients ranged from 2 to 17 years old and not 12, and they have a peak at 5 years. And our policy in the CCHE is to do this mandatory investigation. The MRI of the brain and spinal cord, CSF examination for the ventricle, from the ventricle and from the spine, and full pathological diagnosis and routine general investigation, including liver function, kidney functions, and other chest X-ray and other things, and full neurological and endocrinological investigations. The policy for the CT, MRI, and MR myelography is to make these things for the entire CNS for these reasons. For the primary diagnosis to the brain and the spinal cord, to detect seedling in the brain and the spinal cord, and to assess the amount of post-operative residue. And we have a checklist between the surgeon and the radiologist to detect the residual left after surgery. And they sit together and decide how many centimeters is left after surgery in the post-operative. The post-operative study is done in the first 72 hours after surgery. To do the MRI is to determine the end of the thecal sac. As we will see later on, that it's not as mentioned in the textbook to end at the S2. And to measure the width of the CSF and to document the response of radiotherapy, of course, after we finish the radiotherapy, I mean the chemotherapy as well as the radiotherapy, and for follow-up for the patients to see what's going on in such patients. The protocol for the MRI, as I mentioned, is for on presentation. immediately post-operative in the first 72 hours, and at the end of therapy to assess response and as appropriate during treatment as well as in the follow-up. As we can see here at presentation, there is a large tumor in the posterior fossa. The same patient has a leptomeningeal seedling here in the dorsal vertebrae, at the level of the dorsal vertebrae, as well as here in the, you can see here, in the thecal sac against the sacral vertebrae. After surgery, we assess the tumor and we can find that there is no residual after surgery here, and these are bleeding after surgery. It's blood clot, and it's not there is no residual. And after surgery, there is no residual. There is no tumor left, neither in the brain nor in the spinal cord. This is the Chang staging system, as you all know, and what important to us is the metastatic, the M0, there is no metastasis. M1, it's only in the CSF microscopic cells. M2, cross nodules in the brain, cerebellum or cerebrum. M3 in the spinal subarachnoid, and M4 outside the CNS. Our protocol, as has been illustrated, the same like what has been illustrated by Professor Freeman. We have the standard peak with the residual less than 1.5 centimeter with no metastasis. And we give low dose 23.4 gray craniospinal irradiation with plus posterior fossa irradiation, another 32.4 gray with chemosensitizing and adjuvant chemotherapy. For the high dose, we give higher dose of craniospinal irradiation, 36 gray with 19.8 gray posterior fossa, plus boost, as we will see, according to the site of the residual, also with the chemosensitization and adjuvant chemotherapy. This is the chemosensitization. This is we give vincristine for the low dose, for the low risk as well as the high risk. Vincristine for each week. Here in the day 6, in the first week, until we get the 6th week with the end of radiotherapy, and we will give chemotherapy after another 4 weeks of rest after the craniospinal irradiation. The patient with glioblastoma below 3 years is again the same as what has been discussed by Professor Freeman, that we make initial maximal safe surgical resection, followed by induction chemotherapy, followed by a second surgery if feasible, and then we will give focal conformal radiotherapy and maintenance chemotherapy. We were lucky enough to have only 1 patient treated this way out of the 15 patients we have during these last 6 or 7 months. The radiation dose for the high risk is 36 for craniospinal. Here for the posterior, for the M0, M nodes, we give the craniospinal 36, and we give boost 19.8 up to the level of 55.8. With the M2, we give 19.5 if the tumor is intracranial, and we give the as a boost as for the residual as well as the posterior fossa. For the M3, we give the diffuse form 3.6 gray, making the total dose to the spine 39.6, and the boost, the usual boost to the posterior fossa. If we have focal, we increase this amount to 9 gray if it is still at the spinal cord region, and if it is not, it is below the spinal cord. After the end of the spinal cord, we increase the dose to 14.4 gray, making the dose to raise up to 50.4 gray. The craniospinal irradiation, it depends on the length of the spine, and we may use 2 spinal fields if the length of the spinal cord is more than, if the spinal field is more than 40. The whole spine is treated down to the end of the thecal sac. And we detect the end of the thecal sac individually for each patient. We use the gap between the fields if needed, but we have to do feathering of this gap as the way has been discussed by Professor Freeman. And we don't use the electrons, although some centers use the electrons. They said that this will avoid the dose to the anterior structures. But if we can read this article talking about the electron field they used here 20 million electron volt, and you can see here that there is no difference between the 6 MeV photon and 20 MeV electrons in either the right lung or the left lung. So we don't use the electrons, and we don't use the prone craniospinal irradiation, as we all know that most of our patients, all of our patients are children, and we may need anesthesia, and anesthesia in such position is very difficult, and the position itself is not comfortable to the child. And the only advantage of this technique is that you visualize the spinal field. And with this visualization, we can overcome this with our technique that we will discuss later on. 2 Indian gentlemen published this article around 1 year ago. They use the prone position, but without CT simulation. They use the normal CT, the normal simulator, the conventional simulator, in using this. They put 2 lead marks on the nape, on the posterior of the nape, on the same position, and they put the light and try to put another 2 lines here. They put 2 lines here and try to put another 2 lines near the middle line in the front with two lead marks, and then with the simulator from downwards, they try to get these 4 marks aligned on the same time, on the same line. And so they have fluoroscopy here and try to change the position of this lead mark until it is in the same line. So that's a good technique if you don't have a CT simulator. But with the CT simulator, you save the patients the long period of fluoroscopy that is needed to accomplish this technique. Before we started our study, our work here in the CCHE, we have this piece of work done to assess the width of the spinal cord here, and we discovered that the cervical vertebra is the widest part, and we allocated the end of the thecal sac. The end of the thecal sac, as you can see here, it's only at S2 in only 40% of the patients. Around 30% are above above the S2, and another 30% below the S2. So to say that it is at the S2, that's not correct, and you have to individualize each patient and discover exactly where is the end of the spinal cord. Otherwise, of the thecal sac. Otherwise, you will miss part, and you may get recurrence at this site. Our technique for the craniospinal irradiation, we do immobilization, which is extremely important. We do it in supine position with a thermoplast for the head, as well as a mattress, vacuum mattress for the body. And we may use anesthesia according to the condition of the patient, if he allowed us to do the work without he is immobilized or not. And the dose of radiotherapy is according to the risk, as we just mentioned, and we give booster dose again to the 55.8. We do use, as we mentioned, chemosensitization. This is the work flow of our department. We got our patients mainly from the combined clinic, where we sit with the pediatric oncologist and the neurosurgeon, as well as the pathologist and the radiologist. So at this time, at the combined clinic, we are sure about the status of the patients. We got the patients to be seen in our clinic, and at this clinic, we revise everything again, be sure that everything is the same, and if there is any missing, like mostly sometimes we get the second CSF, because it has to be done 2 weeks after surgery. I mean the spinal CSF. To be done not at the same as the time of surgery, but it has to be after 2 weeks of the surgery. So after that, we decided if the patient is high risk or low risk, we send the patients to the mold room, and we have a CT appointment. We put him on the playroom to play for some time, and then we do the CT scan, and with the CT scan we determine the volume drawn after that by the clinician, and this after we delineate the target volume as well as the organs at risk. And believe me, and for this craniospinal irradiation, we have a lot of organ at risk to draw. And this, after it's drawn, we export this to our colleagues, the physicists, to create a plan. And then the plan is created and exported to the treatment planning system, and they got us a plan, which is a pre-treatment plan, and we have to sit together and check this plan. And after we agreed about the plan, we import the plan and have images created, and all these were passed to the treatment unit after we put the multi-leaf collimators and finalize everything. These will be transported to the treatment machine, and we have to plan to check the plan either the day before or at the first day of treatment. This was done by check setup, and we check the marks of the brain isocenter, because that is our isocenter again, and we do all other centers starting from the brain isocenter. although we are not fixing our treatment like you did in Miguel, but we fix the position. No up and down movement of the patient. The patient has to be on the same plane, but we move it this way, the longitudinal way. And we mark the new marks of the verification, and we do verification either by the electronic portal image device or by the cone beam CT. We do this for the first 3 days of treatment, and then we do it once weekly thereafter. This is the position. This is the head thermoplast. This is the mattress where the patient is laying down with all the imprints of his body on to lay on. And if you can see, I don't know if this is the anesthesia tubes for the patients. And here is the anesthetic equipment. We use the same technique as illustrated by William and Dr. Freeman, and we are very strict, depending on our good fixation. And I was afraid about this, but when William come, he is, as well as Professor Freeman, comfort with our immobilization, so it's okay that we use only half a centimeter. We don't use, we use half a centimeter in the brain as well as half a centimeter in the spinal cord. But we have this to include the spinal ganglia so as to have all the subarachnoid space irradiated. The match of radiotherapy, we use half beam block using only 20 out of the 40 cc's in the spinal cord for the brain, and then we have either one field or 2 fields to the spinal cord. We calculated the collimator angle, but this is not, we use the physical parameters to use it rather than the calculation of the angle itself. But we tested it, and we found ourselves the same as the calculated angle. Here in CCHE, we have some modification of the technique. We put just this custom-made styrofoam board underneath the chest, abdomen, and pelvis of the patient. So it raises the body somewhat, and more importantly, it leads to the straightening of the lordosis and kyphosis of the spinal cord. As we can see here, this is with the board, and this is without the board. With the board, you can see it more or less, it's more straightened. And also the chin or the mandible is out of the radiation from the posterior field. And we tested the isodose. We treated all of our patients with this foam, but we tested the isodose distribution with foam and without foam. And we can reach to this conclusion that it's much better coverage with the foam rather than without foam. And the posterior fossa is not affected by the foam, but this is our giving of posterior fossa. We give the whole posterior fossa. And this is, we tested the, I don't know if you can see it or not, this is the junction area, and we do it in GAF chromic film, and it turned out to be exact, and there is no overlap or underdosage, and so there is no gap for this junction of the cranio-spinal junction. Here is we tested the isodoses for the patients with, same patient without the foam in 6 patients, and the mean dose is much better for the with foam, and it is better, and the maximum dose is better. It's the same for both, but the minimum, but the dose at 95, the volume of the dose receiving 95% of the dose and more is more homogeneous. It's more coverage here, 95.7 rather than 94.3, and it is statistically significant. Those who received more radiotherapy, the volume that received 110 is less with the, much less with the foam. It's 7.7 compared to 26.7, which is statistically significant. The volume also received 105% of the prescribed dose is much lower for the dose with foam. And so the organ at risk is performed, also calculated, and you can find either this is higher than that or that's higher than this. You can conclude easily that there is no affection of the organ at risk with the putting of the foam. This is the portal image that we used to do, and this is the cone beam CT that's produced. And if you can hardly see that there is here, the error is 1 millimeter, 1 millimeter, and 0 millimeter. We have verified the verification error. We tested the error. The systematic error is within the normal, and as well as the mean random error for the cranium as well as for the spinal cord, and there is so that makes us comfortable with our technique. To conclude, the CSI, the craniospinal irradiation, is preferable, especially in children, much safer when anesthesia is needed, and there is the simple physical straightening of the lordosis and kyphosis of the spinal cord by the stylofoam board improves the PTV homogeneity significantly, and this straightening didn't influence the dose to the organ at risk. It may even decrease the dose to some organ at risk, especially for the in the high level. Good embolization and CT-based planning ensure the delivery of radiation without the needs for light field delineation that gives the advantage of the prone position. Verification through EBID or cone beam CT is needed throughout the course of the radiotherapy, and weekly feathering of the spinal fields to guard against over or under dosage of the junction is necessary. And nowadays we are talking about the anatomy of the brain, not in terms of the cerebrum and cerebellum. We are talking about the function of the brain. And so decreasing the dose or increasing the dose has much effect on the function of the dose, especially for children. So the emergence of IMRT is important for the homogeneity of the dose and probably to decrease the organ at risk doses and decrease the dose to the cochlea in the posterior irritation. And we are in the process of implementing IMRT for all of our patients for the craniospinal as well as in the posterior fossa. But till now, we don't have proton facilities as well as McGill don't have it. And these are the coming protocol for our department. We will use the IMRT in the spinal fields and comparison of the 3D with the IMRT is undergoing now, and it has been approved by our colleague here, as well as with William and Professor Freeman, that it's a good plan, and we can. But we will finish with all the patients until we are comfortable with our technique, and then after that we will implement it to all the patients. The use of comparison, we are doing this comparison right now, and this is one of the patients with the IMRT with the a very homogeneous dose to the spinal cord, and this is our team with our two distinguished guests, Professor Freeman as well as Dr. William Barker, and we thank you for your listening. I think if we have any questions, or we can have it right now. No?
I'm having like two questions.
Yes.
In one of your slides, you were saying that you're gonna give a booster dose for residual tumor in the standard risk medulloblastoma, and there is no booster dose for the high risk.
No, I didn't say that. No.
Like
What I said, to make myself clear, that we will give standard risk, instead of giving posterior fossa irradiation, we will give tumor bed. So decrease the volume of irradiation, not to include the whole posterior fossa, to restrict the dose to the tumor bed only.
Yeah, I mean that.
But for the high risk, you have to give the whole posterior fossa.
We were talking like, okay, the craniospinal irradiation, then the posterior fossa or the tumor bed local irradiation, but Dr. Freeman was referring to giving even like
18 gray.
No, I mean a booster dose, a very localized booster dose with IMRT or whatever. Yeah, I mean that craniospinal, then local, then a boost. Am I right? Yeah.
Yes, I think there are situations where you can give more than 54 or 55.8 gray. If you have a high-risk patient with only high risk because of only residual disease in the posterior fossa, I think that if it's feasible, without exceeding the tolerance, for example, of the brainstem, if it's on the brainstem, I think that you can consider a boost of some kind. In fact, it's probably better to use a radiosurgery boost or a boost using stereotactic.
Yeah.
Actually, not radiosurgery, but a few fractions, like 2 or 3 fractions of stereotactically guided radiotherapy, which also we're going to have available very soon.
Should we consider that in our protocol, or I know that you're quite reluctant to exceed the dose.
I am very conservative, so I test things first, and if it works with me, I will go for it. As the same as the IMRT, we don't start with IMRT unless we are very confident with our IMRT. This is one thing. The other thing is to decrease the dose to 18 rather than 23.4. We are waiting for the CCHE trial to give us the answer, and then we will do it. According to their experience.
Again, we were. This is my first question. My second question regarding the infantile medulloblastomas. We were lucky to have only one child that that was having a localized medulloblastoma, and we're giving like a 6-month chemotherapy, and then we go for conformal therapy and a maintenance. But what about having a metastatic disease at presentation? We're quite reluctant to go for high-dose chemotherapy and auto-BMT and then conformal therapy. And we were discussing the possibility of giving, again, a conformal therapy for the seeding mets if it's not diffusely affecting the spine. Is it okay?
You know, I think I tried to say that. I think anything is okay. I think the point is there will be a lot of factors to consider. Are we talking about a 6-month-old, or are we talking about a 2.5-year-old? Yeah. We're talking about different volumes of disease, different extents of disease. There is no right answer. I mean, I had that in the table, but I didn't spend any time looking at it. But the recommendations range from 0 to full dose craniospinal radiotherapy, and I think you have to do the best you can in that kind of situation, which is very difficult. But I think for sure, if there's no macroscopic disease elsewhere, then I don't see why not using conformal radiotherapy to the limited disease.
Yeah, I think we have to think about the bone marrow transplantation in such cases, and conformal radiotherapy. Yeah, high dose. Yeah, high dose with. Okay. Yeah.
Regarding the tolerance of pediatric to radiotherapy, most of people don't give radiotherapy before 3 years, and I have read recently that some people may raise the age to 5 or 7 years for CNS tumor.
Yeah. Actually, my next talk is on radiotherapy for CNS tumors other than medulloblastoma, and I was going to talk about at least our experience with infants with other kinds of tumors, and it depends on the tumor type.
Okay.
Right?
Okay, any other questions? Okay, so, yeah, Professor Hoda.
Is any place for re-irradiation in recurrent cases after surgery, second surgery, after 1 or 2 years?
Re-irradiation after recurrence. Yeah, patient received all the recommended therapy and he recurred.
I showed one example of that. I showed a child who was irradiated at the age of just around 3 years for a medulloblastoma that was considered standard risk, and she received 18 gray craniospinal radiotherapy, and she received a conformal boost to the posterior fossa. She recurred 4 years later with a solitary, in fact, she's the only patient that recurred using supine position craniospinal radiotherapy in our institution. She failed with a solitary lesion on the S1 root that was resected, and then she was re-irradiated because she'd only received 18 gray, and we thought it was feasible to give 23.4 gray. And we then boosted the region of S1. So again, it's very individual. It's not going to be possible if it's a high-risk patient who's received 36 gray. It's less possible in a patient who's received 23.4 gray, or maybe less logical too. I mean, this was low-dose craniospinal radiotherapy and limited recurrence. And she's now well. She's about 3 years following treatment. So I think there's a place. Sometimes it's feasible, sometimes it's not. I don't think we could have done it with any other technique than tomotherapy. In fact, we're just planning now a patient with ependymoma who had full dose treatment to the posterior fossa and failed in the supratentorial brain. And in fact, it's not possible to retreat the area that was treated before without exceeding tolerance of the brainstem. So every case is different for re-irradiation, but it should be considered. We always say that when we discuss cases, we discuss all the options: surgery, radiotherapy, chemotherapy at every time point. So at diagnosis, at time of progression.
So we move to the radiotherapy for pediatric CNS tumor with Professor Freeman.
Okay, so this is on non-medulloblastoma CNS. So I thought probably you've had enough medulloblastoma for the day. So I'm going to just review a little at the beginning about the children's oncology group specifically, and the kinds of and what that group, the goals of that group. So as we know, and it's exactly the same here, about 20% of all malignancies in the pediatric age group are CNS tumors with a peak age incidence between 5 and 9 years, and about a third of patients present before age 5. And 3/4 before age 10, which of course has enormous implications in terms of treatment, not only radiotherapy. There's been significant progress because of improvements in diagnosis, improvements in treatment of all kinds, and again, I would say because of better integration of all the treatment modalities. And the overall survival now in North America in population-based data is around 70%. So what I'm going to do today is I'm going to review the current management of the more common pediatric brain tumors other than medulloblastoma, really with a view to talking about evolving radiotherapy practice and the use of radiotherapy in current clinical trials. Now, the COG-CNS committee is a very active committee that has in fact looked very seriously at radiotherapy in a number of different ways. We've looked at the use of radiotherapy, we've looked at timing of radiotherapy in relation to chemotherapy, we've looked at target volumes and doses, and we have looked and are looking at the application of new technologies. For example, proton therapy is allowable on COG studies. And as I said earlier, quality assurance and education is a very important part of what we do within the Children's Oncology Group. And I just wanted to tell you, because I assume that at least some of you don't know, that the Children's Oncology Groups in North America date back a long time, in fact to the 50s in the case of the CCSG, and to the late 1970s in the case of the POG. And all of the pediatric groups were merged into a single group, the Children's Oncology Group, in the year 2000. And it was reported around a decade ago, and it's probably still pretty much the situation now, that almost all children diagnosed before the age of 15 with malignancies are registered with COG institutions, and about half of those are treated on study. The CNS committee, as I said, is very active. It's chaired and has been for a number of years by a fantastic person, Ian Pollock. I was privileged to be vice chair for a number of years. I gave up that role just last year. But it's a very active committee and a very exciting committee. The objectives overall are, as you see here, to identify biological characteristics that influence treatment response, and the next generation of studies will certainly be looking at risk adaptive stratification based on biological characteristics and molecular characteristics. We have developed fairly comprehensive treatment approaches, as I hope you'll see, with the goal of improving survival or reducing the sequelae of treatment. And in those tumors that are difficult to treat with conventional treatment, we're looking at trying to identify more effective treatments. So for radiotherapy, the overarching strategy or goals to optimize radiotherapy delivery, to optimize chemotherapy, to allow changes in radiotherapy volume or dose or both, and looking at chemotherapy along with radiotherapy to improve efficacy. So I'm going to talk about the larger groups of patients by tumor type and try to trace the developments that have led to current management. So if we start with low-grade gliomas, we know that that's a large percentage of all patients with CNS tumors, a very heterogeneous group characterized by an indolent clinical course. The most common type in the pediatric age group is the pilocytic astrocytoma, WHO grade 1, that typically, as in this lesion in the cerebellum, appear with a well-circumscribed contrast-enhancing nodule, often with cysts, with very little mass effect. And as I said, they usually enhance uniformly with contrast material. But low-grade gliomas are of many different types with many different treatment approaches. For example, a lesion in the tectum that the management will consist of usually third ventriculostomy, and we simply observe the tumor. We don't do any active treatment. A lesion at the cervicomedullary junction where surgery will be the treatment of choice. A lesion in the optic nerve where radiotherapy is certainly an option. But the bottom line here is that not all patients need treatment. The non-enhancing tectal lesions, many tumors in patients with NF1. And surgery is clearly the treatment of choice for low-grade gliomas, including for tumors in locations, such as here in the thalamus, that were previously considered inaccessible to surgery. It's estimated that complete resection is achieved in about 80% of hemispheric tumors and about 40% of midline tumors. And following complete resection, long-term survival is very close to 100%. It's also the case that not all patients that have undergone incomplete resection will progress. So the question is, which patients will progress and which won't? This is an old study of the pediatric oncology group with the CCG before the merge of the groups in 2000, where patients who had undergone complete resection were either followed without adjuvant treatment or else with an incomplete resection, either without adjuvant treatment or with radiotherapy or chemotherapy for patients less than age 5. And this is the progression-free survival published in 2003, where for patients who had a complete response, long-term progression-free survival was really excellent, but any patient with any volume of residual, for any patient with any volume of residual, the risk of recurrence was around 50%. And there were factors, of course, that correlated with survival that we can imagine and were confirmed in this study, including tumor locations. So cerebellar hemisphere lesions did much better than patients with midline tumors, and patients with JPA did better than patients who had WHO grade 2 tumors. So this study, in theory, was to show which patients need early radiotherapy. I don't think that we fully answered that question. But we actually follow this algorithm, which consists of a second surgical resection, if feasible, at the time of progressive disease. And we only intervene with radiotherapy or chemotherapy for patients with progressive disease that's inoperable or not resectable. And this is where current efforts are directed on COG studies. So, for example, this is a study that is now completed, where patients under the age of 10 with progressive disease that was unresectable were, if they were patients with NF, they were treated with carboplatin vincristine. If they were non-NF patients, they were randomized to one of two chemotherapy regimens, the standard carboplatin vincristine or the other regimen that you can see here. And the bottom line here is pretty much the same as the other, the curve that I showed you. So about 50% of patients by 3 years will progress on chemotherapy. Our current strategy is that we use chemotherapy for patients less than age 10 and radiotherapy for all children who are older than 10 or for children less than 10 years of age who have progressed on chemotherapy. We had some discussion the other day at your rounds about exceptions to that rule, and I believe there are exceptions, but that is an overall strategy. With respect to radiotherapy, radiotherapy for low-grade glioma has changed. This is an illustrative case. So a patient was, this was pre-op at the age of 8 years. This was an MRI done just post-operatively, and this was the disease at time of progression at age 11 years. And so treatment in that case would be to the disease at time of progression, not to the original tumor volume. So this is different from what we might have done in the past. So in the first place is more selective use of radiotherapy. We're using a reduced radiotherapy volume that consists, as I said, of the macroscopic disease at the time of resection. And we also use much smaller margins for the CTV for all low-grade gliomas, regardless of grade. If you use very tight margins, though, it's important to repeat the CT scan or the MRI during treatment at around 20 gray to make sure that coverage is still adequate, that there hasn't been any increase in volume of the disease or any cyst, or the cyst, if there is one, hasn't increased in size. And the dose that we use conventionally in North America is 54 gray. In the adult experience, as you know very well, there's probably no difference between 45 to 54 gray, but at this point the pediatric groups haven't made the leap or haven't studied lower doses, but have preferred to focus on volume. This is the current open COG study for patients older than age 10. It's a radiotherapy study again, with treatment exactly as I just described, as pretty much as a standard of care. In other words, optimal treatment planning with CT to MRI co-registration being a prerequisite. The margin for the CTV is 0.5 and the standard radiotherapy dose. And the endpoints, of course, are patterns of failure and long-term sequelae of treatment, include particularly the neuropsychological tests and quality of life. So, in going on to ependymoma, ependymoma is about 5 to 10% of all CNS tumors in children. The median age is young, 2 to 3 years, and about half of all patients occur less than 5 years of age. 2/3 of them arise in the posterior fossa, and about 1/3 are high grade or grade 3 ependymoma. And the spread is primarily local, and less than 10% have leptomeningeal seeding at diagnosis. Workup is as for patients with medulloblastoma, in other words, a postoperative MRI within 24 to 48 hours of the surgery, an MRI of the spine, and CSF cytology. And the management in the first instance is clearly surgery. In the literature, one reads that macroscopically complete resection is achieved in about 80% of supratentorial and spinal tumors, but a much lesser percentage of infratentorial tumors. And there are many issues with respect to management, including the need for postoperative radiotherapy in all patients. With respect to radiotherapy, the target volume and dose, the role of chemotherapy is not clear, nor is the role of second-look surgery. And there's a question, too, of the timing of radiotherapy in infants and very young children. And there may indeed be a group of patients for whom radiotherapy is unnecessary. Patients with low-grade ependymomas of the spinal cord do very well with after surgery alone. And so probably to patients with supratentorial low-grade ependymomas, although the standard of care at this time is still postoperative radiotherapy, and observation is really only acceptable in a research study setting. For radiotherapy, we know that the risk of seeding overall is quite small. In the past, CSI was the standard of care, craniospinal radiotherapy, but in fact we know very well now that the predominant pattern of failure is local, so that local radiotherapy is the standard of care for all patients who do not have evidence of spread at diagnosis. So the GTV is pretty much as we described for medulloblastomas, so the tumor bed, together with any macroscopic residual disease. It's important to take into account any anatomy. We use data on extent of disease from preoperative and postoperative imaging, but it's important to take into account any anatomic changes that have taken place since the surgery. And the margin can be quite limited, around 1 centimeter margin is quite reasonable. The radiotherapy dose is high. It's higher than for other tumors because of the evidence in the literature that suggests that survival is better with higher radiation doses. And the current standard of care in North America would be a dose of 59.4 gray. But obviously, it's important to do a field size reduction of the brainstem, and this may again require alternative approaches such as a boost using fractionated stereotactic irradiation or some other modality to limit the core dose. And just 2 examples of radiotherapy fields. One on the left, a child, 2-year-old girl, almost 3-year-old girl, with minimal residual disease in the posterior fossa following surgery. She was treated with IMRT to 54 gray and then coned down to a small volume with actually very good sparing of the brainstem. On the right-hand side, this is a patient with an anaplastic ependymoma who had had an almost subtotal resection or minimal enhancement in the tumor bed, and the patient was treated with IMRT to give a slightly higher dose per fraction and a higher total dose to the tumor bed compared with the CTV. These are the kind of results that you can see now using good radiotherapy. This is from Tom Merchant at St. Jude's, published in 2004, with patients with well-differentiated histology, grade 2, doing particularly well, with 90% overall survival using conformal radiotherapy following surgery. Patients with complete resection did much better than patients with less than complete resection. You can see here 78% versus 43%. This is the COG study that was completed last year or at the end of 2007. The results have not yet been published, but this is exactly the same as your schema for your patients. So for patients with supratentorial, well-differentiated histology, there was no postoperative radiotherapy. This is actually a rather small group of patients. I know the numbers are small in this arm. The number of patients who had a gross total resection and went on to radiotherapy is much higher than anticipated. In other words, higher than the, let's say, 40% complete resection rate that we read in the literature. So more patients are having more complete surgery than in the past. And then for patients who had less than total resection, they went on to receive chemotherapy, second look surgery if possible, and then on to radiotherapy after that. And as I said, the results are not yet available from this study, but this is an absolutely reasonable approach to the management of ependymoma. And the other thing I should point out is that this is for all children from 12 months to 21 years. So as I said before, more patients are having complete resection than in the past. Local radiotherapy is really the standard of care to high doses, to 59.4 Gray as a standard. For patients who have residual tumor, a strategy that includes chemotherapy followed by second look surgery followed by radiotherapy is totally reasonable. Talking now for a few minutes about intracranial germ cell tumors. As you know, these are rare tumors, or they're rare in the West. The peak age incidence is early teens with a male preponderance. They arise either in the region of the pineal region or in the suprasellar region. Pineal region tumors obstruct CSF flow early and usually present with signs of raised intracranial pressure of short duration, and the majority of those will be non-germinoma germ cell tumors. Tumors in the suprasellar region tend to present with symptoms of longer duration and usually neuroendocrine deficits and only later visual field deficits. Diagnosis is not always made on tissue, because tissue is not always available. Imaging findings can certainly help by looking at location or appearance, but if the CSF cytology is not positive or if tumor markers are not diagnostic, biopsy is now mandatory prior to treatment, because the differential diagnosis of lesions in this region includes a number of different entities that would all be managed quite differently. Looking at treatment approaches, in the past these patients would all have been treated with craniospinal radiotherapy, but it's important to know that multifocal disease or subependymal spread present in about 10%, CSF cytology is positive at diagnosis in about 10%, in patients with germinoma a bit higher frequency in patients with non-germinoma germ cell tumor. The workup includes tumor markers, the MRI of the spinal axis, and CSF cytology. For patients with germinoma, they will have had a biopsy for diagnosis. There are treatment options. There are several treatment options, including craniospinal radiotherapy. And the long-term disease-free survival following craniospinal radiotherapy is very high, very close to 100%, as for example in the German experience here. But there are other options other than craniospinal radiotherapy, including limited volume radiotherapy or chemotherapy followed by radiotherapy. If radiotherapy is used to treat, if we treat only to local fields, there is a higher rate of failure, and in fact, results appear to be better with larger volumes, for example, whole ventricular radiation, as in this case. And in North America, this would be a standard for patients receiving treatment with radiotherapy alone. More focal radiotherapy is probably a reasonable approach for patients who are going to be receiving chemotherapy as well, although there are reports of failures outside the target volume, particularly from the French group. This is the current COG study, which is a very difficult study and is not yet completed, but hopefully will be, because it's asking an important question. It's comparing standard radiotherapy alone, which in North America, as I said, would be defined as whole ventricular radiotherapy with a boost to the primary site, versus 2 cycles of chemotherapy followed by reduced dose radiotherapy. Patients who have less than a complete response to the 2 cycles of chemotherapy would go on to receive further chemotherapy and standard dose radiotherapy. So this is an open study. It's incomplete at this point, but hopefully it will be completed. Non-germinoma germ cell tumors are difficult to manage. The diagnosis is made in a substantial proportion of cases on the basis of imaging and tumor markers. The results are very poor with radiotherapy alone or with chemotherapy alone, so that the standard of care in North America has evolved into chemotherapy followed by radiotherapy. This is now a completed study of the COG, where patients were treated with chemotherapy, carboplatin and ifosfamide, followed by radiotherapy, and the radiotherapy for all patients would be CSI. For patients who have an incomplete response, we consider a second look surgery before going on to radiotherapy. Patients who have residual disease at this point go on to high-dose chemotherapy with stem cell rescue before finishing treatment with radiotherapy. But as I say, the radiotherapy, now I understand what's happening. And so the radiotherapy for all patients is craniospinal radiotherapy. But we're thinking of changing that. And it's quite likely the next study in the next study, patients will be stratified on the basis of the type of the risk category and the marker level. And it's quite likely that we'll be looking to reduce therapy by reducing radiotherapy target volume from CSI to whole ventricular radiation. The higher risk group, it's likely that the treatment for the higher risk group will remain pretty much the same with some slight changes. So as I said, in response to the question, I'm just going to spend a few minutes talking about CNS tumors in infants. As I said, this is not a small problem actually. In fact, about 33% of all CNS tumors occur in the under 5 age group. The largest category for us is medulloblastoma PNET, followed by low-grade gliomas, followed by ependymomas. And the clinical presentation is usually with signs and symptoms of raised intracranial pressure. And sometimes these tumors are just enormous, and the percentage of patients who have CNS dissemination at diagnosis is in general higher than in older age groups. And as I said, treatment, especially but not only radiotherapy, is associated with a substantial risk of morbidity. Surgery is an important component of treatment. It can be the only treatment in some patients. But for all other patients, the focus of studies in North America and elsewhere over the last couple of decades has been on the avoidance of radiotherapy whenever possible. But chemotherapy alone results in objective responses in only about 40% of patients, and the median time to progression is rather short. And if the goal is to continue chemotherapy up to age 3, quite a number of patients will progress before that, and not all of those patients will be salvaged. So treatment now is according to the specific tumor type. For low-grade glioma, usually the treatment is surgery, chemotherapy if necessary. We try to avoid radiotherapy until age 10 if at all possible. For ependymoma, as I showed you, all patients over the age of 12 will be treated with, according to the schema that I showed you, so that there are children aged over the age of 12 months and below the age of 3 or 5 years that will be receiving local radiotherapy as post-operative treatment. For other children, treatment may consist of chemotherapy followed by second look surgery, possibly followed by radiotherapy. For M0 medulloblastoma, we talked about that. So conformal radiotherapy, not craniospinal radiotherapy. And for the group of patients, these are all actually now treated on different protocols, but the overall approach is the same. Chemotherapy, often including myeloablative chemotherapy with stem cell rescue, and then radiotherapy that depends on the disease, the age, and the response to treatment. So I'm coming to the high-grade gliomas and brainstem gliomas. These are very difficult patients, as you know very well, with a very poor outcome. And our goals really are to identify an effective treatment, which we haven't done yet. In high-grade gliomas, this is not an insignificant problem. It's about 10% of all CNS tumors in children in North America. The peak age is around 9 years rather. About 2/3 arise in the cerebral hemispheres and about 1/3 in deep midline structures or the cerebellum. The prognosis is better than in adults, but still very poor, with an overall survival at 5 years of around 5 years. And again, this is population-based outcome data. There are factors that we know to correlate with outcome, including younger age, complete resection and location in the cerebral hemispheres, which are favorable factors. Patients with bithalamic tumors do very badly. So I don't think we can really call anything in high-grade gliomas progress, but I think we have confirmed the importance of a complete resection, and we've begun to identify correlates of outcome in terms of biological markers. And these are just a couple of slides from Ian Pollock based on COG data showing that a high MIB1 proliferation index predicts a worse outcome. P53 overexpression also correlates with outcome. So the strategy for us is for all newly diagnosed patients, we use radiotherapy up front, high-dose radiotherapy, but there's really no evidence that a dose graded 55 gray is any, or 59 gray is any better than 55 gray, so that's certainly debatable, given in combination with chemotherapy. And we have done a series of studies that each accrue about 100 patients over a 12 to 18-month period, with event-free survival as the endpoint, or progression-free survival. So the current studies, recently completed studies, are radiotherapy with temozolomide, radiotherapy plus temozolomide, followed by radiotherapy with CCNU. The results are superimposable, and there's absolutely no evidence that either temozolomide or temozolomide plus CCNU have improved outcome. Planned studies include radiotherapy with newer chemotherapy plus or minus biological agents. So currently the management for high-grade gliomas is post-operative radiotherapy for all patients, the tumor bed plus any residual macroscopic disease and peritumoral edema. We saw a patient like this week with a margin of 1.5 to 2 centimeters, a high total dose, once daily fractionation. Obviously you need to consider a dose volume reduction of sensitive structures such as the chiasma if it's feasible. And there's no advantage for radiosurgical BOOs, brachytherapy, hyperfractionated radiotherapy, and high-grade glioma. IMRT or accelerated radiotherapy to the GTV may be of interest to shorten treatment. That may be something that may be worthwhile looking at. And at this time, as I said, there's really no established role for any systemic treatment, but having said that, all patients have systemic treatment as well. Just finally, diffuse intrinsic brainstem tumors. This is also not a small problem in children. These account for about 10% of all CNS tumors and about 70% of all brainstem tumors. Most of them arise exactly as you see here in the pons. They're very aggressive tumors with symptoms of short duration and a very characteristic appearance on MRI. And we don't routinely require biopsy in the context of typical clinical and imaging findings, and there's no role for surgery. Radiotherapy is a useful treatment that results in a worthwhile improvement in a very worthwhile improvement usually in the vast majority of patients. You can usually, if patients are taking dexamethasone pre-treatment, you can usually taper that by 2 to 3 weeks into treatment, but the course is extremely predictable with a median time to progression of 6 months and a median survival time of only 11 months. And survival at 2 years is only around 10%. So in brainstem glioma, we have used hyperfractionated radiotherapy and shown that there's a baseline event-free survival at 1 year of 17%, but absolutely no evidence of any benefit from hyperfractionated radiotherapy. So that our current strategy is to use radiosensitization using chemotherapy or other agents. And again, we're using the same sequential design as for high-grade gliomas. So these are the recently completed studies. A number of new agents are proposed to be integrated into the follow-up studies. So in the COG, we've looked at many different aspects of the use of radiotherapy, which I think has been very helpful in terms of defining a standard of care. And several of the current studies really do have a potential to result in practice change in radiotherapy. It's clear, as I tried to say as we've gone along, that the next studies, patients will be stratified on the basis of biological markers, which is quite exciting because it opens up other potential avenues for treatment. And radiotherapy, I'm sure, will remain a very important component of treatment, and particularly if using all of the new technologies, we can show it can be delivered more safely. So thank you.
Okay, so good afternoon again. I know the afternoon's getting long. You should try standing here. I'm going to talk today about something about all the new toys that are available in radiotherapy and our experience implementing them. So that'll be IMRT, IGRT, and SBRT. So we'll start with IGRT. We classify IGRT into two categories, forward planned and inverse planned. And generally, IMRT, what happens is gantry angles are defined and fields are defined, and then these fields are subdivided into small, either subfields or beamlets. If the number of beamlets is small, we can do a forward plan, and we saw that with the medulloblastoma case where we used 3 segments or 4 segments to actually compensate the dose over the entire spinal field. But if we want to do some serious critical structure sparing and boosting of GTVs and targets, we need to start to think about dividing each field into many smaller beamlets. And this, of course, becomes impossible for a planner to figure out what the beam intensities required would be. So we would call this inverse planned IMRT, where a computer helps us with the optimization process. You saw the slide from Dr. Freeman. I'm only going to talk about, in this part, LINAC-based IMRT. I spoke about tomotherapy before. So this basically comes in 2 flavors. We have static delivery MLC. So this is the multi-leaf collimator, and it's very easy to understand. We just add differently weighted fields together until we get a dose distribution, but we can deliver also using a moving MLC and get the same dose distribution. This is very difficult to understand. It's not intuitive at all, but it provides us with a very quick delivery that's very efficient. This is kind of the schema for the IMRT process. Of course, it starts like with all radiotherapy processes nowadays with the acquisition of a CT scan for a patient and careful organ delineation. Beam geometry is defined. We give the computer something called planning constraints. So this can be the goal of the plan, but more often than not, we have to adjust the parameters so that the optimization process can find a good solution. Once a solution is found, beam intensity matrices are created to treat in order to deliver this type of conformal dose. So over here we see the beam. This would be the beam's eye view, and the red portions of this picture are where the beam is, and the darker portions would be of higher intensity. And again, we would use an MLC to deliver this. Dr. Freeman spoke a lot about this, and of course, precise target and critical structure delineation is key. This is an adult head and neck example, but it would be the same for a pediatric patient nonetheless. And no sloppy contouring is allowed. So this has to be done very well and very precisely, and everything has to be outlined. So not just a high dose volume over here or a CTV, but also the critical structures that we would want to spare, the spinal cord and other organs at risk, such as the parotid glands. And we were having discussions this week downstairs in the clinic, and when physicians draw these things, they should be drawing them as if they're the isodose lines that they want to treat, because that's what the system's going to do. So they should be very carefully designed. It's a bit blurry, but most systems work the exact same way. Once you define the 7 gantry angles or 5 gantry angles you want to use, or 3, you basically put points on your, I guess, dream DVH. So we can start with that, and then assign for each structure a point on the DVH, but also an importance. So this particular system is a NOMO system by Corvus. We've had it for about 10 years. It works very well, and we can give a structure classification of basic, expendable, critical, and depending on how you classify it, it makes it more or less important in the optimization process. The end result, of course, is modulated fields. These are 4 out of the 7 fields, and you can see each field treats the organs at risk differently. You see this white band over here avoiding the spinal cord here and here too, but this field doesn't seem to care too much about it. Applying these fields back to the CT scan, we end up with very conformal, very tight dose distribution. This particular patient has probably 54 gray to this yellow target, or maybe 60 gray, and a boost probably up to 70 gray to the gross tumor volume over here. We have good parotid gland sparing, and of course the spinal cord is of great importance. So I thought I'd kind of review the summary of indications at our clinic for IMRT. Simply stated, we believe that all head and neck cases should be treated with IMRT. We're able to give an accelerated fractionation, a single plan. So gone are the multiple field setups, the use of electrons or boosts. So the actual planning, even though it may seem longer at the beginning, is actually a much more efficient process, even though the physics guys end up doing a lot of QA. Critical structure sparing, so any case that requires acute critical structure sparing would be a good candidate. We can do the simultaneous integrated boosts, so that can also be more efficient for treatment, and geometrically and anatomically complex cases, so a thyroid or cervical esophagus, pelvic nodes, these are classic cases. One big market for us, well, when they come, are previously treated cases, especially cases that are being treated to full dose, like a head and neck case, where the spinal cord's already at 45 or higher, and brainstem and so forth, and we need to retreat. So IMRT is good for that too. I kind of showed a little bit of this example before, but we can get very, very good sparing. This example is with tomotherapy, so we can get very, very high conformality and uniformity of dose in the target with excellent cochlear sparing. So this would be an example of critical structure sparing. Actually, I should have shown more pelvic nodes over here, but in this particular case, we have one physician that likes to give an in-field boost or a simultaneous boost to the GTV while treating rectal patients. So this yellow line is the 45 gray line, the red line in here is the 60 gray line, and we can give this all in 25 fractions. Coming back more a little bit to the pediatric or adolescent theme, we've used IMRT to the treatment of Hodgkin's lymphoma, in particular if we're only treating the involved mediastinal nodes. We can get very good heart sparing, and this may be of importance, particularly if the patient is receiving certain types of chemotherapy. A very conformal dose, but we can also get very, very good lung sparing as well. Recurrent disease. I believe you need IMRT to do this. So to give the spinal cord, say, less than 10 gray, if you want to treat a recurrence to very high dose, say another 60 gray. So this works exceptionally well. And like I said, this is one of the main indications for us. This particular patient had been treated previously to full dose. And again, we had to treat this rather large lesion while sparing the cord, and it was too deep for electrons. Maybe the protons would have been good. But we have to be careful in the application of IMRT. We learned the hard way. We went into it very quickly, and we thought we were doing it. And at the time when we started, it was about 10 years ago, and we actually didn't really know what a good plan was. So we actually treated these patients like this. We thought this was a good plan, and we have 110% hotspots here, 100% hotspots here. This is actually a 17-year-old girl, and we have this huge hotspot here in the mandible. But at the time, our experience was limited, and you work 3 days on a plan and nothing's changing. You think that that's the best plan. So we learned from this, but you have to be very careful. And like we were discussing downstairs with the guys, they said it took a long time to get that very nice medulloblastoma plan that Dr. Mohammed was showing, and it takes a very long time to become good at this. There are some tricks you can do. A lot of head and neck cases end up with this arbitrary hotspot in the posterior neck. So putting in a structure and naming it or making it an avoidance structure here, or maybe the oral cavity, you can actually instruct the system not to put dose there. The IMRT system is only going to be as good as your delineation and as good as your planning. It doesn't do much thinking, it just does calculating. So if you don't want it to put dose here, you have to draw something and tell it, don't put dose here. Same thing in the posterior neck. Other things, the margins of error are fairly small, especially if we use things like concave or convex targets. So patient setup errors can result in a big geographical miss and overdosing of critical structures. We have an example over here. This is an old slide, but I think it gives a message. This was the original plan that we wanted to give, a fairly conformal, good sparing. We have a GTV covered by high dose line and a CTV by a lower dose line. What we did, this is part of a large study we did, but what we did was we took a CT 3 weeks into treatment and just put the same beams on the patient and recalculated the dose distribution. And not only had the tumor seemed to have shifted, it was all different shape, but the whole dose distribution was not even hitting the right spot in the patient. Now, I got to admit, the distribution looks worse than the DVH did, but still, we don't want the spinal cord creeping into the areas of high dose. Famous problem. This slide is from an AAPM summer school. I didn't put the gentleman's name down. It's Dr. Gary Adele. He works in Scottsdale. And I think this proves a very good point. Some of you may know there have been some bad skin reactions from head and neck treatments using IMRT. And he described why this could possibly be by doing this simple experiment. So he proposed an IMRT treatment for this spherical object over here, circular object, inside a body contour. And in this particular case, he's placed the target 5 millimeters below the skin, and here's 0 millimeters below the skin. And he's asked the planning system to do the exact same thing. And the result is, when the target is delineated, giving some space here for the buildup region, we end up with a reasonable distribution. But when it isn't, what ends up happening is the treatment planning system sees a very low dose area over here and tries to compensate, and we end up getting very hot doses on the surface. This, coupled with the tangential beam delivery, can result in this. And we also learned this the hard way and had a few patients like that until we re-examined everything. And I've got to say, it took us a couple of years before we got the contouring down to an art, and when we didn't have to ask questions, and this didn't happen. One case of neuroblastoma, and I want to use this case to kind of introduce the next topic. So this is a child, obviously, with neuroblastoma, but look at the size of the margins. We can use IMRT to maybe spare some of the anterior structures here, but it's of limited use if we're using huge margins. Remember, PTVs are healthy tissue, and healthy tissue should be minimized, or the size of the PTV should be minimized in order to reduce the effects of radiation on that healthy tissue. If we go back to the ICRU guidelines, here are the two books. These should be read very carefully by everyone, and their guidelines followed. They define the planning target volume. And just a quick review on what these things are. The planning target volume includes the GTV and the CTV, which is a clinical target volume, which is your region at risk. It's actually what you want to treat. But we make the PTV big enough so that no matter where the CTV is, it's always inside the PTV. Okay? The problem is that all of this in blue is healthy tissue. So the goal is to minimize this. ICRU 62 defines a concept of an internal and a setup margin, and they are added onto the CTV to create the PTV. So the CTV can be reduced by a better medical knowledge of the patient or maybe improved imaging, and the PTV can be reduced by several ways. The internal margin is due to motion during treatment. So if we can manage the motion or suppress it using gated delivery or motion suppression, we can reduce the internal margin, and we'll see how to do that later. The setup margin is due to setup uncertainty. So if you can reduce that, for instance, by imaging every day, using relevant imaging every day, we may be able to reduce that margin too. And even just using regular port filming every day is a form of IGRT and can reduce margins. The IGRT, we'll talk about that first. My opinion, it's basically daily pre-treatment imaging to account for patient setup. Okay, so the problem with radiotherapy, of course, is that you don't usually see the tumor, you just see the patient, right? And we're lining up on skin marks. But if we image in such a way that we can see the tumor, either by using a cone beam or a tomotherapy, and we do this every day, then we can reduce that margin. We can also do intrafraction imaging. So within each fraction, there are a couple of systems which allow you to track either the tumor or some surrogate, like a bony landmark or an implanted marker. And this will allow us to also reduce the PTV. So what do we have for pre-treatment imaging? I spoke previously about tomotherapy. They use MVCT, and I believe the system downstairs also uses MVCT, but there are other manufacturers that have mounted fluoroscopic systems right on their Linac. So this would be the conventional MV portal imager with they'll call it an EPID, an electronic portal imaging device. And then they've mounted an X-ray tube over here with a flat panel detector capable of producing diagnostic quality images. So I know we're probably not interested in seeing just bone for most of our cases, but we can implant fiducial markers or for lesions in the lung. This is actually quite useful, and you can compare the DRR or a fluoro simulation image to the actual treatment image, which is now of a higher quality. But the addition of a kilovoltage imaging source over here and flat panel imager allows us to do cone beam CT, okay? And this is what they do downstairs. And the cone beam CT is not as good a quality as the CT used for simulation, but it gives us enough of the landmarks such that we can position the patient very well and thus reduce the treatment margin. In terms of intra-treatment imaging, I'm just going to show you a couple of the solutions that are available. This is from BrainLab and Varian. It's a Novalis linear accelerator that's been fitted with all the imaging you can imagine. There are X-rays, tubes in the floor that aim at flat panel imagers that hang from the ceiling. There is a KV fluoro imaging device. Just like I showed previously, there's a regular megavoltage imaging device, a 6 degree of freedom treatment couch, and even an infrared camera. And they feel that with all of these devices that they can track anything at any time in the patient. More kind of fancy and very much in style in the United States is the use of the CyberKnife or robotic arm LINAC. So this LINAC is actually taken from the auto industry, and they've mounted an Expand 6MV LINAC here. And it uses all manner of imaging like this and aims these tiny little pencil beams at the patient and images right before every pencil beam is delivered. Now, this doesn't result in a very efficient delivery, but it results in a very accurate and precise delivery. So let's talk now about SBRT. This is stereotactic body radiation therapy, and it's a treatment method used to deliver a high dose of radiation to the target using either a single dose or a small number of fractions with a high degree of precision within the body. This is the definition by the American College of Radiology. But really I want to talk about it because it pulls in several of the advanced techniques that we're using in the clinic now. So it's a combination of techniques. You have to do stuff at the patient simulation time. You have to employ very good immobilization and localization of treatment time. You have to be good at planning. You have to know your prescription. And of course, you have to apply IGRT. There's also quite a lot of quality assurance and treatment verification because we can be employing some very, very high doses extracranially. So this slide just shows that the percentage of cases that are being used for SBRT. So you can see graphically over here, this is a spinal, this is something in the neck, this is something in the liver, and this is something in the brain. But this actually includes radiosurgery also, so stereotactic intracranial radiosurgery. But I want to talk about a couple of the newer studies, well, new, O2, studies that are being carried out now, namely in lung and liver and spine. So in the adult kind of cancer community, this is what they're looking at, giving very focused, very high doses of radiation. The RTOG 0618 is a protocol that plans to treat very small lung lesions like this one to 60 gray in 3 fractions. So that's 20 gray per fractions given once a week. 0236 did the same thing, and it was an extremely successful protocol that just closed. The liver protocol, I believe, can treat either metastases or primary liver lesions, and that's more, it's an escalating dose protocol, but they can treat up to something like 45 gray in 5 to 10 fractions. So we have to be very careful and very precise about the actual delivery. So for pediatric applications, I was speaking to Dr. Freeman, certainly we can use a lot of these SBRT techniques to reduce the margin and maybe even use some of the higher dose delivery techniques for palliative cases. The main components of an SBRT program, if you had everything available, you'd want accurate, reproducible, and relevant target immobilization. And we would like to suppress target motion somehow. So if it's an abdominal or a thoracic target, we would like to do a CT simulation to account for respiratory motion. We'll talk about that next. And then definitely do pre-treatment localization imaging. The better the modality, the better the treatment, I would suppose. And also, ideally, we don't do this, too bad, but we would like to do intra-treatment imaging to allow for target tracking. This is just a couple, I don't want to fall down. This is just a couple of examples of immobilization systems used. We use something like this It's by a company called Medical Intelligence. It's a double vacuum system so that the patient is placed on a very rigid backlock, and another piece of paper, a piece of plastic is put on top, and then air is pumped out. So the patient is effectively shrink wrapped. But it works fairly well. Other companies use abdominal compression. I don't think this is as painful as it looks, but the system is available for purchase. One thing that we do have to be careful of and want to take into account are breathing artifacts and moving targets. And you can actually see the effect of a moving target on a CT scan. So this is a very classic picture. I don't know where the certainly this isn't our CT scanner, but we see the same type of problem all the time. So if you have a slow scan through a CT scanner or a single slice scanner and a target is moving, you're going to get these motion artifacts. And this is very well known and understood. And if you're able to gate your scan, you're able to actually see what the shape of the tumor is like. And in fact, if you can gate your delivery, we have a considerable reduction in the size of the target. And this figure up here just kind of shows potentially the distortion in shapes that you would see. And we see this all the time in lung tumors, of the distortion in shape of the actual thing. So if we had gated CT, this is a ball that someone had CT'd, and we have the ball move up and down. If we take into account the gating, we always image the ball. But if we're using a single slice, a slow scanner, and we don't take into account the gating, then we end up with distortions at different parts of the motion cycle. This is what we use. We use a surrogate system, or a system that actually tracks breathing cycle through abdominal motion. So there's a lot of links in the chain here, as they say, but we put a little marker block here, and there's an infrared camera that actually measures this, and then this information can be fed back to the CT scanner system. And if we use a system like this, we can do two types of simulation, and I'm just going to define these quickly. A 4D CT is simply a scanner that can reorganize the images according to location in the breathing cycle. So you scan the patient once and end up with 10 different or 5 different CT scans with the slices actually categorized into different phases. Or in a 3D scanner, you can use gated acquisition, but you can only acquire one cycle at a time. So this would be a 3D CT scanning. So this is the breathing trace of, well, the abdominal motion trace, which we believe is a breathing trace of the patient. And we can tell it to only acquire the CT image, for instance, on expiration. So it would acquire one here, one here, one here, one here. And if you use the same device at treatment, you may be able to reduce your margin and only treat on expiration. A 4D scanner affords you a little bit more flexibility. It just acquires images all the time, but because it's also connected to the machine, it can tag each image with each phase of the respiratory cycle. So our scanner can do up to 10 phases. This, I just show 4 over here, for example. What we do for CT, we first do what we call a free breathing scan. So we see if actually motion is a problem by looking for these artifacts and checking on several images. So if we know that from fluoroscopy or from some other test that we're expecting a spherical target, and we scan the patient and we get something like this, then we know the target is moving. At this point, we can choose to treat a larger field to take into account for the motion. Thanks. Here we see a liver case which has a target identified. And what's interesting about this is that breathing motion results in an inferior-superior motion of targets. If we look at the 2 axial scans over here, this is the target. They look identical. But in fact, there's actually motion on this scan. If we choose not to treat with a gated regime, then we're going to have to expand our PTV over here, because this thing, we expect this to move during the treatment on this motion. If we do gate at treatment, then we're able to just focus a radiation over here and then turn the beam on and off as the patient is treated. This is our CT room and just all the gadgets that we need to use this to gain our PTV reduction. So these are obviously people. This is the patient, and this is our medical intelligence device. We actually have a stereotactic localizing box, although there's not much stereotactic about the technique because you have to image before you treat. And we always move the patient because the patient, it's almost impossible to put him in here to the millimeter. There's the plastic that goes over the patient, and then there's a vacuum pump down here. This is the little marker box that which will reflect infrared light to this camera system over here, which is connected to the CT scanner itself. We can get very nice scans with this particular system. If we don't use it, or if we use it incorrectly, like we did the first time, we get horrendous scans. In fact, even worse as if we didn't use the system before. To prove to ourselves that the system actually worked, the manufacturer sends this little phantom, and it's like a little device with a circle here that provides an eccentric motion for this marker block, and this thing goes up and down. And if we gate properly and say only acquire when the box is at the bottom of its up and down cycle, we end up with a very nice picture like this. If we're not gating and we're still acquiring during the motion of this, you can see that we get a warped image. And this is happening inside patients if you don't gate. So we have to take this into account. Treatment planning. This is an example of one of our cases. It's a lung stereotactic, a 25 gray in one fraction. We use 7 fields, all 6 MV, and a prescription at 80 to 85%. So there are some points in the patient getting over 30 gray. One thing which I haven't shown here, but people should be knowledgeable about, is the use of heterogeneity corrections for these things. They don't always work very well for small fields, but you can expect an increase in 10 to 15% in your dose if you don't use them. The protocol guidelines are quite vague on their use too, so just something to see. So we have a plan. We put the patient on the machine, and the first thing we do is we do a pre-treatment film. Luckily for lung lesions, they're actually viewable on and visible on a portal imaging device. Okay, so this would be the DRR, and we usually, well, for this case, we had put a clip. This is actually a lung case, and this is a liver case. So the liver, you really can't see it very well unless it's the upper parts of the liver near the diaphragm. You can't see it very well. So we put platinum coils in the liver, and then these can be seen on the treatment EPID. Just to be sure, once we start treatment, we're able to fluoroscopically acquire images during treatment. And again, for lung lesions or lesions which have clips in them, this is actually interesting because we're able to make sure that the target always stays within the radiation field. So let me see if this kind of goes. This is a sequence of a few images showing for us that the actual target stayed in there. Now, if the target is immobile or is not moving very much, we're able to use tomotherapy. Currently, we're unable to gate treatments with tomotherapy, but if the target is not moving, we don't have to gate. But the advantage of tomotherapy is that we get excellent pre-treatment imaging, and it gives excellent dose distributions, very, very tight. This is, again, 25 gray in 1. For those who are scared, this is the 8 gray volume. We routinely give 8 gray APPA, so I think this is a reasonable treatment. But what's interesting is the actual pre-treatment imaging that we can do with very, very, very precise localization of it. And you see they've had to move the patient by a centimeter here just to treat right on the lesion. So now, this loaded up right away. So what about quality assurance for these things? We have some tests that we do. This is a little phantom that the girls on the CT do every morning, on the tomo do every morning. So they place it at a known offset, and then they can image it and make sure that it comes back to the proper location. If we want to get physics involved, we can put little bits of film in here and connect this to ion chambers. And then for IMRT, we have also well-established techniques that can be used with film, different types of film, ion chambers, and things like that. But nothing is better to complete your QA program than participating in clinical protocols or trials. Dr. Freeman spent a long time today talking about all of the trials. And you can't just join a trial nowadays. Well, maybe you can, but not the ones that we join. You have to participate in a trial and then participate in a credentialing process. And the credentialing process is carried out by a quality assurance group, something like the Quark in Boston, or RTOG themselves, or even the Radiological Physics Center in Houston. And they carry out many tests on your institution. They will actually come up and measure your beams. They have a mail-in TLD program, but for specific protocols, they'll send you a CT data set and ask you to plan. So they'll ask you to outline, make sure it's okay, and do the plan, send a sample QA, and they'll check your calculation algorithm. If you do a motion control, they'll send you a moving phantom, and they'll test your localization imaging. So it's something very nice that actually closes the loop. We've done almost all of them. Actually, this week we just received the lung phantom, but we've done several head and neck irradiations. So they'll send you something like this. This is from MD Anderson in Houston. That's where the RPC is located. And they send you a head, and it's got this plastic insert inside. And inside you can put a film and several measurement devices in here. You close it up, fill the head with water, CT scan it. You plan it, and then you treat it. And then you send the whole thing back to Houston, and they send you a full report telling you if you've hit the target or not. They have several ones of these. This is the actually the lung one. And you can see here we've tried to do a conformal plan. So I think in summary, I'd just like to say that IMRT increases conformality and allows for integrated boosts. IGRT can help in reducing PTV margins, which are healthy tissue, and allows for a sparing of those healthy tissues. And then SBRT is a combination of techniques that allow for radiosurgical type doses up to 20 grays per fraction or higher to extracranial targets. And lots of QA. Thanks. One more talk. I promise. Okay, so I'm going to switch gears a little bit. During our visit this week to the radiotherapy department, we spent a long time talking about quality assurance and quality assurance processes. So we'll just summarize some of those discussions and talk about a modern quality assurance program in radiotherapy. Okay. So I'll just give an overview of our quality assurance program. Dr. Freeman obviously developed a lot of this, but it starts with a good quality assurance committee that oversees documentation, patient case reviews, treatment planning quality assurance, equipment quality assurance, treatment delivery quality assurance, but also includes other things that other people you may not think are part of a quality assurance program, but they are, and that includes event and incident reporting, participation in clinical trials as discussed, auditing of your facility, accreditation, and also educating and having teaching sessions on this. Our QA committee has a lot of people, and the meetings take a long time, but we think it's worth it. We only meet 4 times a year or so. But it's important that it reports through the chair to the hospital quality assurance committee. I believe here you have now a quality council, and that reports directly to the CEO of the hospital. We have various people, obviously all of the chiefs and all of the staff or representatives from all of the staff groups, including therapists and nurses. We have hospital representatives that come down to, and patient representatives, lawyers sometimes come, risk management specialists, and hospital administrators. The QA committee can spin off subcommittees that can actually work on small projects or So all these subcommittees, and we've got many of them, patient care committees with nurses, chart reviews, medical physics, and we can go all the way around. I'm going to talk later on about the event reporting committee. A typical agenda would include, when we meet, reports from these various subcommittees, review of any major incidents and events, review of how long are patients waiting for treatment. Here I see it's not a problem. It's a problem for us. Discussion of previous meetings, action items. So if someone said they were going to do something, just check to see if they still haven't done it. And any mortality or morbidity reports, of course. In terms of documentation, we're just getting rid of our paper chart, but I think complete documentation for the patient is important, whether it be paper or electronic. And departmental procedures also have to be documented, and a good policy and procedure manual is extremely important, documentation of incident reports, and records of quality assurance. So if something goes wrong, you can look back and see if it's been going on like that for a long time or not. I'll talk a little bit now about our electronic file. We've installed a very expensive information system, which is, we feel most of the time, very good. Sometimes it's a little slow, but it does the job essentially very well. And it does everything for us. So it's an integrated suite. It's a treatment record. It controls the linear accelerators. It also has all of the patient documentation in it. We can do treatment planning with it. There's a PAC system for image archiving and retrieval. Scheduling, all the department scheduling is done on it for patients. We can do treatment verification and quality assurance with it, and even keep track of things like medications lists, etc. This is what the front page looks like. And it has basic information about the patients and a lot of radiotherapy stuff up front, of course. This is our business, so how many patients, how many treatments the patient has received. And interestingly, I think they're expanding into chemotherapy too, so to have a chemotherapy module with this, any alerts or messages about the patients and what all of the patient appointments are. But all of these tabs lead to a different part of the system. We can have a list of the treatment fields used, the monitor units, how much dose is being delivered. And we can actually check the actual technical parameters for every field used and even look at the verification imaging over. If there's any treatment time imaging, it would appear down here too. Patient case review is something that's very important. We discussed that this week. At our site, believe it or not, we actually review every single case within 5 days of treatment. So there's probably 40 people that sit in a room, all the physicians, all the residents, a few physicists, planning personnel, all of these people sit in a room and listen to usually a resident or registrar, you'd call them here, say something about the consultation note, maybe confirm a pathology, describe the dose prescription, and then we'll look at the verification imaging, for some cases a dose distribution. This all happens within 5 days of start. Now this is time consuming. We've actually had to go to 2 hours per week, so we have a curative session on Tuesday mornings and we have a palliative session on Wednesday mornings, and we're able to review this number of patients. So that's about 2 minutes per patient, so it has to be efficient and effective. And remember, we have no paper chart, so the residents are doing a lot of work the night before, or a little work, I suspect. In terms of treatment plans, we have all treatment plans are reviewed by a second planner. So we have dosimetrists in Canada. They're treatment planning specialists, usually therapists from the machine. One person does the plan and another person reviews the plan. And then the MD now must go to the computer terminal and review every slice of the plan. And then a physicist does the same thing, and then it gives a final approval to the plan. It's actually the physicist's signature which allows the treatment to proceed. 2 therapists also verify the data transfer to the treatment units. These are people on the machine. So there's basically something like 7 or 8 checks before someone gets treatment. The types of things that we might look at a dose distribution, this is a paper distribution. Hopefully this won't exist by the time we get back. But things like the beam parameters, isocenters, monitor unit calculations, normalization, and the verification images, these are all types of things that we check. And to check a plan, it probably takes 15 minutes. And that's it. Another aspect of QA, of course, is equipment QA. Well, physicists familiar with this is the water tank used for 3D measurements and PDDs up here. There's routine QA. There's acceptance, commissioning. All these are quality assurance process. Post-breakdown QA and patient-specific QA. And we've seen some of those things in the past. At the treatment machines, I didn't get a picture, but patients, the key is to identify patients well. I noticed you guys on your patient list, a lot of the patients have the same name, so photographs are probably important. Us too, we have sometimes that problem. SSD measurements at time of treatment can confirm that the right plan's been loaded. Verification imaging we feel is very important and should be done definitely on the first day of treatment and repeated at a scheduled interval. Treatment parameters should be checked at the machine. Blind loading of patients from the information system, that should be somehow checked. And then, of course, the documentation has to be up to date and proper for the patient. We had a case once where the tech or the therapist took off for lunch or something, and we didn't know if the patient had been treated or not. And we were in the embarrassing situation that we had to ask the patient if they had received treatment today. Now, that's kind of, I'm not going to call it old style QA, because we're still doing that. But there appears to be a new mandate for quality assurance in radiation therapy, and it involves a risk assessment and risk management. This all was introduced to the field at a conference that I was lucky to be at in Dallas in 2007. So all of these catastrophic incidents that I'm showing over here look pretty bad, and they're always on CNN, but they actually don't happen very often. Something like 2 billion people fly every year, and less than 1,000 people die. And all of these industries have extremely effective quality assurance mechanisms based around preventing organizational accidents. So how can we apply some of the theory behind the quality control that happens in these types of industries to radiotherapy? Excuse me. So risk management actually integrates a recognition and assessment of risk with the development of strategies to mitigate or reduce that risk, and the emphasis is now on looking at your departmental processes and actually identifying what the riskiest processes are. So we're going to talk about a couple of ways to do that. Once you've done that, we can develop QA programs specifically to prevent harm coming to patients. So instead of just doing QA because a piece of equipment is there, really evaluate what QA you're doing on that equipment, the frequency, if you need to be doing it, or if you need to be doing more, or if you're lacking in other processes. So the CCHE model, I'm sure everyone has at some point in time laid their eyes on this, but basically an organization can be divided into a series, we'll call them quality assurance procedures. And no one has perfect quality assurance, and if each one of these is a procedure, say in a phase of your process, so we start with requisition for treatment and prescription, treatment planning, treatment delivery, and verification imaging. I mean, this is a generic concept that we've just applied to radiotherapy. If the procedures are inadequate, they can probably make a little hole here in the Swiss cheese. And the more problems and inadequacies that you have in your process, the more holes you have. And usually problems happen when there are several failures in your system. So the arrow goes right through the Swiss cheese hole. And I'm sure if you look back in your radiotherapy, all the mistakes that have happened, it's never the last person that pushed the button or whatever. It's usually a failure of documentation, of communication, a series of different things. So I found this slide interesting, and I'll just go through it quickly. This is something called a safety culture, and it's been separated into 3 groups over here: a pathological safety culture, a bureaucratic safety culture, and a generative safety culture. I believe most radiotherapy, including ourselves, hopefully until recently, but we're somewhere in between over here, not something like this. A pathological culture would be something where you're not interested in knowing the failure modes. You just kind of close your eyes and let it go. Messengers or people that tell on other people are considered to be bad and not good, and bad workers. There's little responsibility, a lot of finger pointing. He did it. Consequences, the failure is usually punished or hidden. Don't tell anyone we did that. And new ideas and innovation are discouraged because they may actually raise new QA procedures. Bureaucratics in between, but in the generative, we actually look for failure modes. Messengers are actually rewarded and told, good job, you found that there's something wrong in our system. It's a shared responsibility with accountability, though. The consequence of finding something is that we change something to make the process better, and new ideas are actually welcomed. So we've taken a two kind of pronged approach at risk management, a retrospective approach, and hopefully when we get to it, a prospective kind of a forward-thinking approach. So we developed a radiation therapy-specific event reporting program. That's the first part. So in the past, when something happens in the radiotherapy department, a mistake, it's mostly treatment delivery errors. Not much else is documented. And it's very vague reporting structure. So something would happen at the machine, maybe you call the doctor, maybe you call a physicist, you just kind of all talk it over, and you're like, okay, it won't happen again. You write a note in the chart, and that's it. And I see people laughing, because that's what happens. But no one else learns from this. You're just it just becomes an event, and nothing comes out of it. So the documentation and course of action was certainly very varied. No real database. And also, it must be said, events in radiotherapy happen so infrequently that usually people with good intentions start programs. But when you're getting 13 or 14 errors a year, usually the programs just die and people stop doing them. And again, the education is usually restricted to just those people involved. This is our current incident report form from the hospital, and this is supposed to cover medication errors, radiation errors, surgical errors, people falling in the parking lot, all kinds of errors. And it didn't make very much sense to us to use this form to describe something that's so detailed, such as radiation therapy. So our proposal was to, first of all, increase staff awareness. It occurred to us that I believe in 2006 we only had 80 reports of things happening. 80. Okay, we treat 160 patients a day, something like 45,000 fractions a year, and only 80 things ever went wrong. We wanted to standardize reporting, create a database and categorize the events, and then analyze that database and see if we could do anything to improve our quality assurance. We formed an event report committee. We meet twice a month. So not exactly twice a month. We try to meet twice a month. And we review and classify all the events. And this committee generates reports to the Radiation Oncology Quality Assurance Committee, and those reports are passed on right to the hospital administration. And this committee is also responsible for the database maintenance. So we instilled the following plan. We wanted a dedicated radiation oncology forum, so something that would help us, and anonymous reporting, so blameless reporting. So someone could just deposit the form in the boss's office, no names or anything, just to let us know that something had happened. Classify the events and make a database. Oh, disclosure. Very important. There's actually laws, so we basically tell the patient right away when something's happened. Event reporting committee, Dr. Freeman is on it. I guess I'm on it. There's a few other people that are on it. Sometimes we get help from the hospital risk management. They come and tell us if our program is good, and we do that. And this reports right up through to the hospital, right up to the administration. So what happens? An event happens. The report. Someone in the report committee is informed. A form is filled out. It's evaluated, the MD is informed, the patient's informed, the event is documented. So this can be actually 5 minutes, or it can be a longer time. It depends. And then a decision is made whether the treatment continues or is actually stopped. So what do we report? Well, we report any treatment interruption. Okay, so if a patient doesn't receive treatment one day, we report it. We want to know why. Any unplanned delays in the start of a treatment. A patient is scheduled to go on Monday. If he starts on Tuesday, it's like something happened and he got 0 dose on Monday. So that's how we consider it. Accidents, so we'll talk about these next. They're classified. And we even classify, we even write or document technical errors, clerical errors, or medical problems. So it's quite wide. The scope is quite wide. Accidents 1A and B are defined by the AAPM TG35 and ICRP 86. So these are documents that are widely available. And an accident 1A would be considered a sentinel event. And this would be a 25% total overdose. Okay, so not over one fraction, but total overdose. And events involving, the treatment of the incorrect patient or incorrect body part are also classified here. And 1B events are 5 to 25% overdose, and most underdoses, depending on what it is. We also document near misses, so when something is brought up and it's fixed, we write it down. Any near miss is an event which could have produced an accident if not caught, so that's written down. Serious adverse accidents, so this is to do with treatment toxicity. Unfortunately, the program hasn't really taken off too well with that. But we also record equipment failures and other types of incidents. This is our form. I mean, it's pretty straightforward. People can just fill this out, and then we categorize the event. The department is broken down into 4 major phases and then a bunch of sub-phases. So every time we get an event, we kind of circle here what was involved, and then that goes into the database. And for example, in the treatment planning phase, there's a category of errors like the wrong patient identification or images, documentation incorrect, data entry incorrect, treatment planning, just a bad plan, treatment planning system broken, all kinds of things like that. We also looked at errors. We wanted to know why people were making mistakes. Were they making mistakes, or was it a lapse? So a mistake is something that you think about and make a decision and it's wrong. Okay, and a lapse is just, you're just clicking away at your mouse and all of a sudden, oops, something like that. It's kind of subconscious, and we have attentional slips and the slips of memory. But mistakes are usually breaks in procedures or decisions. Okay, you make a decision. There's not that many of these. We'll take a look at that. This is over the first, I believe, 15 months. So in that time, we had 3,800 new patients, 3,800. And that amounted to 56,000 fractions, okay? And we recorded 633 events. So there's different ways you can look at this. You can say, hey, we only had 1.1% of fractions where there was an event. But you can also look at it by saying, hey, that's 16% of all patients had some kind of problem with them. But in the previous 12 months, and this goes to show how education and awareness is important, we only had 88 events recorded. This is a breakdown of what we had. We only had, luckily, 14 accidents, so overdose or underdose of patients, which is great considering the volume that we have. We had 94 near misses, though, which could have resulted in accidents. And then we have 525 other stuff. Equipment failures are recorded, and this is each machine and the number of failures for each machine and the number of canceled appointments as a result of that. So it's a good mechanism to actually track that, to see how many appointments we're losing because of broken equipment. This is what the database looks like. I can't read it and you can't read it, so we'll just go on. And then we've also isolated the events by process phase. So computer-related events, patient management rounds, patient. Like sometimes a patient, I'm not waiting anymore. They walk out. That's an event. Dosimetry, simulation, and so on and so forth. Human errors. We discovered that about half the errors are attentional lapses or memory lapses, and maybe 35–40% are actually mistakes. So people have thought about mistakes, or they're inventing procedures or not using procedures. This happens too. The second part, and this will be shorter, I promise, is looking at a failure modes and effects analysis. Okay, and this would be like looking forward to see what the problems would be for your department. There's been a new group formed. It's in North America. TG100 it's called. So there was the older group was TG40, and they kind of laid out a comprehensive document for quality assurance in radiation oncology. This is going to be the new document, and I'm sure the IAEA will follow. But it's going to be based on risk assessment, and we'll consider systems instead of components of a system. So not just calibrate a LINAC 3 times a week, why you're calibrating the LINAC 3 times a week. It's going to use things like process trees and failure modes. I actually don't know who's going to do all of this work because it's going to be a lot of work. I'm going to show you. This is the process tree for IMRT. This is the general process tree. So this is the treatment. So patient arrives and gets treated. But in there, we have diagnosis, and we have, I can read it here, decision to treat, imaging, treatment planning, plan approval. And every one of these is going to be broken down into individual steps, and we're going to assign a risk coefficient to it. And then decide from that, list all the risk coefficients and see what needs QA. So just look at the first day that a patient comes to treat. These are all of the things that happen on the first day. Patient arrives, you identify the patient, you put the patient on the table, you line up the patient on the lasers, you put the patient straight, you take their clothes off, you do this, you do that. And every one of those, you're supposed to come up with a coefficient. It's called a risk probability number. And it's got it's got three coefficients, one for probability of failure, one for severity of the resulting effect, and one for the probability that you're not going to see this. So the severity, so 1 would have no effect, and 10 would be a catastrophic event. The patient dies or something like that. And you're going to do one for the frequency of occurrence. So if you expect the event, for instance, happen more than 5% of the time, then you would give it a 10. And the likelihood of detection. So if less than 80% of the time you're going to detect it, you're going to give it a 10. So all of these things you're going to do, you're going to come up with a score. And no one's actually decided what score is going to make something important, but some score, some number here, they're going to say maybe everything over 300 has to have a special QA procedure or something like that. TG100 will provide examples for IMRT and high dose rate brachytherapy. The question is, are we going to have to make our own in our hospitals, or can we just use those? And can it be customized to individual departments, like I said? But this seems to be extremely long and time consuming. Again, I don't know if I'm going to be the guy ending up doing it, but we'll see. We don't have any risk experts in the department. We do have some in the hospital. So let's just summarize. Event reporting, the response from the staff has been positive. The events are reported at least 5 times the previous year's rate. More data is being analyzed, and we're examining new clinical workflows as a result. The failure modes analysis. So these new QA systems will use risk assessment. We'll do process QA if we can, and we may do failure analysis. We're going to start with a small part of our clinic to see if it actually does us any good. And I think that's it. So I'd like to thank Dr. Mohammed Saad for his excellent team and hospitality during the time. Dr. Freeman with her new friend this morning at the pyramids. So I think that's how you say it. Shukran. Thank you very much. Any questions?
Yeah, thank you very much, Professor Freeman and Dr. William. And are there any questions? May I ask you a simple question? What degree of QA did you find in our department? Yeah, for both of you.
No, it's no problem. I found that there's quite a lot of QA being done, but the documentation has to be formalized for the quality assurance. And closing some loops also, like everybody. So performing tests which will test the whole process as opposed to it. But in general, patients are definitely being treated safely. It's also a small department, so relatively small in terms of numbers compared to ours. I think you guys have something like 16 staff. A place like ours has 160 staff, so the quality assurance programs can differ a little bit. They all fit in a very small room, actually.
This was the first documentation for the quality assurance we did.
That's it.
Professor Freeman and
Right.
Dr. William, and we wrote everything as a document. And although we documented things like the quality assurance for the machine, machines. We documented all the quality assurance for the treatment itself, but the procedures itself. We agreed upon a process of documentation for the process, all the process, and we are going to follow this very strictly.
That's it. So the idea of having, no matter how small the group, of having weekly patient reviews for everyone, even if both doctors saw the patient, maybe someone else can say something. So this will be a regular thing. I think we've agreed that we're going to have a radiation oncology quality assurance committee to make sure all the documentation is done and that answers to the quality council of the hospital. So things like that. But certainly it's a very nice department. And like we said, we just have to formalize a lot of the interactions are oral or between people, which works reasonably well with a small group. But if you guys get any bigger, you know, it could be more problematic. But certainly I think it's very good. And like we said, we feel everything was done, just it's got to be a process managed.
Again, we thank you very much for your stay for us this week, Professor Carolyn Freeman and Dr. William Parker. And we hope that we will come again and enjoy the weather here.
It's fantastic, and it's a beautiful hospital. Thank you very much.
Yeah, we hope so too. It was a very enjoyable week, and thank you very much indeed.
Thank you again. And thank you all for your listening and attendance.